So, Anupam, Rachna, good morning. Anupam, have you joined? Yeah.
Good morning.
Yeah, Rachna,
Good morning.
good morning.
Good
So,
morning.
all set? मतलब,
Yes, all set. Anupam से पूरा presentation भी
Calling
आ गए हैं
you.
सारे.
Rachna, I'm calling you, huh?
Okay.
okay, good. So, yeah, all the speakers for the first session are there. Dr. Pragya, Dr. Tanu.
Yes, sir.
Yes, sir.
I think everyone is there. Yeah, okay. So maybe Vishal, maybe you
Yes,
can
I'm here.
start maybe live session.
I had just one question from Tanu.
Okay.
Tanu,
Yeah, Pragya.
Yeah, I'm there, Tanu.
Bihar,
I thought
Pragya.
who's asking?
Huh?
Anupam.
Anupam is asking. Pragya has sent a separate presentation, and your presentation covers both. So,
Yeah.
No, we are presenting the same. The first half I am doing it, and the second half Tanu is doing because it's the cumulative finding of UP and Bihar.
so there won't be any separate presentation for you.
No separate presentations.
No, it will
Yeah,
be
the
the
same.
same one because the time allotted is only 15 minutes. So we
Okay.
have divided the section.
Okay.
And we
तो
shared a new presentation with Dr. Amir yesterday.
अच्छा ठीक है तो फिर ये है कि there will be only one presentation. First half Pragya will be doing, second half Dr. Tanu will be doing, and you will be sharing your slide from your this one computer, na?
Yeah.
Yeah, I'll share my screen, and once I am done, I'll exit, and Tanu will share her screen.
Right.
Tanu, you will be sharing.
I'll be sharing the continuing part.
Okay. तो मुझे नहीं slide share करने का जो this morning.
No.
मैं जब खोल के देखी तो I got confused.
No.
Okay. चलो क्योंकि first is yours only, ना?
Yeah.
चलो good. Thank you so much. Thank you.
So I think Vishal, we are live. I think, right, Vishal?
Yeah, अभी live किया है ना? So now we are live. Okay, so
sorry, there is a mistake. We are not alive, but we are also thriving. It's alive and thrive.
Yes. Yes, only alive, being alive doesn't make sense. So we have to thrive, sustain.
Being alive is necessary, but not sufficient.
Yes, not sufficient. Right. So we are alive, and with all you partners and everyone, we are thriving. Right. Okay, so maybe should we wait for maybe few 2 to 3, 4 minutes, right? Maybe we can start by
yes,
10.
It is not
10,
still 10. It is still not 10 o'clock. So I think it would be unfair to.
Yes, we'll wait now. Yeah.
We have a very friendly secretary.
So it's a friendly?
Friendly secretary.
Yes.
Good morning, Bhatia sir.
Iska Shailesh keep a deadline for bringing out the proceedings. He should not go into a 5-year plan.
No. Definitely, it will be there. I think within next a few days. Hey, because the discussions based on yesterday's discussion, and I am hopeful that today's discussion, lot of good deliberation will be there, and so definitely we would like to take this forward as immediately as possible.
The exciting part of this entire journey is we are dealing with real people in real time with real problems. So it's all alive and thriving. It's all alive. इसमें कोई there is no hypothetical study, na? So that makes it more interesting and exciting. This is called problem-based learning. When I was studying at McMaster, that university in 1971 established this program called problem-based learning. They had an MBBS course or MD course for only 3 years. And anybody, whether you did music, history, geography, topography, arithmetic, anybody could be admitted. So they used to admit 100 students, and 2/3 were girls. So the first day started with the clinic by seeing a patient. And then they studied about everything about the patient in terms of anatomy, physiology. So it's a problem-based learning, very well established model, 1971. McMaster University, Hamilton, Canada. So that's what we're practicing on a large scale. Actually, if you look at life, when you start walking, your mother is behind you. So that's the first problem you start in life, that you start walking with your mother's protection. Your mother is Shailesh Jagtap and his team, and the children are the participants in this program.
Shailesh, it's already 10 o'clock and we are live now. Okay.
Yes. So maybe just a few more minutes, we will start the session, right?
Sure. And we are live on YouTube also.
Good morning, everyone.
Because we are. Good morning, ma'am. Hello.
Shailesh, can you hear me clearly?
Yes, you are audible, clear.
Madam is audible but not visible. She's behaving like coronavirus.
I'm not visible. But I have. Good morning.
Madam, you're audible but not visible.
I know. Now I think I'm visible, sir. How are you?
I'm fine. Thank you so much. धन्यवाद इस संवाद के आपने जो आयोजन किया है इसके लिए हम आप सबको धन्यवाद देते हैं.
A lot of credit, Dr. Amit doing tremendous work.
You see, a new norm has been established because of Corona. They're called Corona warriors. These are warriors of alive and thrive.
Thank you, sir.
Hello, Dr. Alok. Dr. Alok is also here.
Good morning, Dr. Amit. Amazing work yesterday. I missed it.
Thank you, ma'am. Thank you for all the support to IAPSM. Hello, Ratan Srivastava, sir. Good morning.
Hello, good morning.
बहुत अच्छा लग रहा है कि हम आप लोगों को यहाँ रहते हुए देख पा रहे हैं और बात कर पा रहे हैं. ये सारी देन जो है, ये सारी एडवांटेज या बेनिफिट कोरोना की है. उसके पहले हम इतने काबिल नहीं थे, हम लोग इतने एफिशिएंट नहीं थे कि घर बैठ के या ऑफिस में बैठ के एक दूसरे को देख सकें. उसके लिए काफी पैसा खर्च करना पड़ता था, ट्रेवल करना पड़ता था. एक दिन पहले हमें याद है डॉक्टर शैलेश जगताप, हम लोग जब इकट्ठे हुए थे दिल्ली में, तो एक बहुत बड़े से होटल में हम लोगों को रुकना पड़ा, तभी मीटिंग कर पाए थे हम लोग. लेकिन ये वी आर थैंकफुल टू कोरोना कि उसने एक नया प्लेटफॉर्म दिया है हम सबको कि कितनी भी मुश्किल हो हम लोग मिलेंगे जरूर और अपने काम में सफल रहेंगे, डिस्कशन करेंगे. इट्स सो नाइस. डॉक्टर शिवांती को भी मैं
Good morning. Good morning, sir.
I can see Dr. C.S. Pandav, and it's really very pleasant to see each one people. Yes, so nice.
So definitely, Corona infection has made us how we should be resilient enough to adapt in any situation. And a lot of best examples like how people have adopted school children going on online classes, online work from home, and many things. Yes, obviously there are a lot of challenges due to this pandemic also, but then people are adapting, changing their approaches, behavior, lifestyle, everything. I think. But just one example I can give, like I'm in a society, it's a biggest society township in Noida, and I'm seeing people, but even elder ones, started cycling on the road and using cycling. It's only kids, and now so this is a big change towards the lifestyle, you can say, that this pandemic has brought.
Dr. Srivastava, as usual, he has always stole the thunder from my words. There are only two words that are guiding my life. One is gratitude. Gratitude,
Yes.
Shukrana, and second is forgiveness. Maaf karo.
Demonstration start.
तो आपने हमारा gratitude.
Am I audible?
Yes, good morning, Dr. Ramba. You are audible.
It's very nice to see everyone here. You all have given us a good platform to meet and see everyone during COVID times.
It's refreshing to see each other.
Yes, yes, very refreshing. Very refreshing.
तो कोरोना ने हमको सिर्फ रोना नहीं सिखाया, हंसना भी सिखाया. तो हम रोते हंसेंगे, हंसते हंसते रोएंगे.
सर हमें कोरोना से लड़ना भी सिखाया है. Sir, I have faced corona. I was suffering from it last month.
Oh, I see.
Come out of it. So it's a big challenge, sir. Suffering from it is a nightmare, I would say. It's very different from other diseases.
So you got already doctorate in corona?
Yes.
The doctorate ka long form is
experiential learning. And today she'll be talking about curriculum.
Amir bhai, when I said doctorate, PhD is Doctor of Philosophy. But when you have corona, it's called Pagal ho gaya dimag, PhD.
One more advantage of this meeting is that we can see faces of other person without mask, because we all are sitting alone in our room. Otherwise, always we wear some mask and we hide 50% of our face. So that is a great advantage. And we have no fear while talking with each other and facing each other. It's really, I can see the smart face of Dr. Amir. Yes, smiling face, cheerful young boy. Yes, very nice to see Amir.
So the next question in the examination is, what are the disadvantages and advantages of having corona? Madam, I have deep sympathy with you since you have recently recovered from corona. But at some do share your experience. I'm sure it must be agonizing, also exciting.
Very different. The thing is, since we are not able to take help and support from family members, it becomes very difficult for us to actually go through the whole process. And we are always scared of complications, because oximeter to ghar pe hai, but that oximeter is actually functioning properly or not. It becomes very difficult for us to actually rely on it once you are in home quarantine. So finally, it's better to be in hospital because you can get care immediately.
Here, I'll take this opportunity to explain you 3 words: sympathy, empathy, and compassion. Sympathy only expressed, madam, aapko dukh hai. Lekin empathy is the stage that you're going, you're experiencing that thing. Film actors is an excellent example. Compassion is where you try to adapt the root cause of pain and suffering. That's compassion. Sympathy, empathy, compassion, which is absolutely missing from our discipline. What our discipline focuses on naturopathy, puttapathy, allopathy, homeopathy, but no sympathy, empathy, and compassion. So that's the new norm that we have to follow. Shailesh?
Yes, sir.
New syllabus, new norm and new syllabus. Sympathy, empathy, and compassion. Not allopathy, homeopathy, telepathy, puttapathy, tilupathy.
Sir, any pathy will have a greater impact with the three pathies that you have mentioned: sympathy, empathy. Otherwise, they do not have any value as such. It just become a profession. So these are very much interlinked, right?
But sir, I must say our healthcare professionals are doing excellent job. The way they are devoting time, energy, everything, and the way they are facing this problem, I would really appreciate them. Once you go through the whole process, then you realize how much difficult it is.
Actually, madam, Dr. Pathak, whenever I participate in a webinar, the first thing I say is gratitude. Gratitude to the health professionals, the physicians, the nurses, the support staff, the drivers, the sanitary workers, law and order. They have decided to choose, they have made a choice to go into the valley of death. They've taken the risk of going into the valley of death. So they're real warriors.
Yes, sir. Yes, sir.
Amir bhai, I've said what I want to say. Can I go?
नहीं सर, प्लीज सर, आप साथ रहेंगे सर. हेलो डॉक्टर सुरेखा किशोर मैम, डॉक्टर राकेश कक्कड़ सर, डॉक्टर चैंतेल.
I think we should start now. I think we have a good number of participants also, and I think hopefully next few minutes it will rise. I think.
Can I take, Amir bhai, can I take a minute from you?
Arey sir, please, sir. Arey sir, please.
I'll be in Gandhi Dham on 21st of October to celebrate the Iodine Deficiency Disorder Day with the iodine salt producers from Gujarat. Anybody from Gujarat, you're most welcome to join. Gujarat Chamber of Commerce, 21st October, World Iodine Deficiency Disorders Day. And we have done exceedingly well. Today we are leading the world in terms of evidence-based data as well as the coverage of adequate iodine salt. Unprecedented. We are going to celebrate the success after celebrating this conference, which has been an extraordinary conference. We're moving from one success story to another success story.
Thank you, sir.
Shailesh, wait for the wait for the proposal for funding.
Sure.
I am losing my sleep, sir, for the next phase of proposal and seeing how to draft it. Alok is here, he is going to say, what is Shivanti saying? That's what we are working right now.
All that we are asking is give us 1 rupee and lots of blessing. 1 रुपया दीजिएगा, क्योंकि सबसे बड़ा रुपया होता है.
But sir, one thing before we start, I think I'll share it with everyone. Some of us here know about it. The third Poshancon progress report has featured the work of the monitoring of the quality of nutrition services by Medical College, Community Medicine and IAPSM team in UP and Bihar. It has come out just recently in the public domain after approval from PMO office. So all the people here at IAPSM, and I know people from the medical colleges, Dr. Pragya, Dr. Tonu, all are here today presenting this story. But I felt like sharing this, that this is very encouraging, and much appreciate the hard work and the leadership role from IAPSM and the medical colleges.
As I mentioned always, this is an incredible connectivity that has taken place. I'm especially proud of the medical colleges that have chosen, not the usual AIMS type 22 ones. You have chosen ones which are neglected historically, and they have done excellently job done, So there is talent everywhere. Only thing is they need an exposure. कल हम बताया था कि आजकल आसमान में हमें तारे नहीं नजर आते. मैंने पूछा तारे कहाँ हैं? सारे तारे IAPSM के कॉन्फ्रेंस में बैठे. सारे सितारे जमीन पे आए हमारे कॉन्फ्रेंस में.
Okay, sir. We are starting today's session. So welcome all and good morning everyone to this first MIYCN conference of the IAPSM. And this is the second day of our conference. And I am sure that you all had enjoyed the first day session with our esteemed speakers from ministry, from Niti Aayog, and our expert representatives from IAPSM who had discussed about the research component and role of IAPSM members, what can be done. So with this exciting start yesterday, so now we look forward to this second day of the session. And I assure you that this day will also be very much interesting because all the speakers, all the panelists are here with the good deliberations. There are good, interesting topics, and we will have a deep dive into this concept of maternal, infant, young child nutrition, going deeper into the understanding of more towards the implementation aspect of it at the different platform. So welcome you all again to all the participants, to all the speakers. So now I will go to the first session. So our first session is on quality assessment. And what can I say about this quality assessment? So we will be having a first-hand experience from our good speakers from the medical colleges on their first-hand experience of interacting with the community, frontline workers, and even with the government system, and what were the findings and how. So now I will start with For this session, I will start with introducing with the chairpersons. Anupam, may I request the profiles of the chairpersons to be shared? So I would like to first invite Dr. Pandav sir, and I think whatever I speak about him would be very less, and I may not be able to justify to his profile. So he's a sort of a mentor. He's a mentor to everyone, and his yesterday's speech was really a motivating to all the public health persons, and his knack of presenting, simplifying it with few words, પાંચ words, 2 words, 3 words. I think that is a interesting introduction to him for me, I can say from my side. And apart from that, his career, more a very long career in public health. So he was a former professor and head with Center for Community Medicine with AIMS, and now currently he is the member of National Council of India Nutrition Challenges, and he has been heading the various national and international associations for his work related to iodine deficiency disorders. So he is the president of Indian Coalition for Control of Iodine Deficiency Disorders and chairperson for Coalition of Food and Nutrition Security. So I think with his introduction, now I would like to invite another chairperson to this session on quality assessment. So we have here with our dynamic Dr. C.M. Singh, who is the professor of community and family medicine from AIMS Patna. He is the vice president, IPHA North Zone, and he had been engaged in many important projects through AIMS Patna and in his previous career. So around 40 plus projects are in his kitty. And with this COVID situation, he is the co-PI for the Covaxin trials through AIMS Patna Geography. And he is also the chief editor and Indian Journal of Community Medicine, Community Health. So welcome you all. Welcome you, Dr. C.M. Singh. And the third chairperson for this session is Dr. Dinesh Marthulia, and he's a very jolly go person, and I think very dynamic. He is the professor and head Department of Community Medicine and principal GMC Saharanpur, and we have a good association with him to the same project when he was the head of the department with the Kanauj Medical College. So I welcome you, Dr. Dinesh Marthulia. So with this, now I hand over to the chairpersons to conduct the session on quality assessment. Over to you, sir. So you have to unmute. I would request all the chairpersons to unmute themselves. Yeah.
Okay, good morning, everybody. Can I request Dr. D.S. Marthulia and Dr. C.M. Singh to take over the proceedings? Today, I'll be a silent listener. If required, I'll say something. Dr. Marthulia, please.
Dr. Srivastava sir, Dr. Pandav sir, it's nice to meet you all in this small screen. And today we all are here in this conference for the quality assessment with our speakers, expert in their field. And I welcome you all in this conference. Thank you.
So I would request the chairperson to introduce the session of our speakers for this session.
So speakers.
Anupam, please put the slide of Dr. Pragya.
Yes, Anupam.
So I invite our first speaker, Dr. Pragya, for her presentation.
This will stop Yes.
Okay.
So, good morning to the respected chairpersons and all esteemed faculty to this conference. And I'll be speaking on quality assessment in Poshan Abhiyan. So, it started with this was a joint venture of IAPSM with support from Alive and Thrive. And the recommendations were given to the Niti Aayog for the future, deciding future course of action. So the main key objective, which was there, it was to review the quality of the health and nutrition services at the various delivery point in both UP and Bihar. In Bihar, we have chosen Muzaffarpur district, and in UP, it was the Kannauj, because it was a then the second objective was to what was the quality of supportive supervision, which was provided to the frontline level worker by the top level officials, and then to identify what was the gap in the terms of the quantity and in terms of the quality of the supportive supervision which they were providing. And then with the key finding, the recommendations, it was planned to send the recommendations to the Niti Aayog. So this it was basically, as I have already told, Kannauj in UP and Muzaffarpur in Bihar. That was taken, and it started in July 2019 and ended in February 2020. In this, basically, we have taken 19 community-based event, and in that CB 8 was God Bharai, and the rest was the Annaprashan. God Bharai Divas is celebrated for the this antenatal women on 7th of every month, and this Annaprashan was basically, it is a community-based event for starting of the complementary feeding of the 6 to 23 months of old children. So it in Bihar, it is being celebrated on 19th of every month, if it is a working day. And 11 sessions of the Village Health and Sanitation and Nutrition Day, we call it as a VHSND, it was observed. Then we interviewed 6 block medical officers, and we have interviewed 57 frontline worker and the supervisor, which included the ANM, ASHA, Anganwadi worker. We have observed 6 block level health facilities, and we interviewed 79 beneficiaries, which included the pregnant women, lactating women, and mothers of children 6 to 23 months of age. We performed the exit interview of the women who came to the health facility for availing the services. And there also the beneficiaries were the pregnant women, lactating women, and mothers of children 6 to 23 months of age. So if we see the key findings, which we have interviewed with this frontline level worker, then the positive finding which we have observed, that was like the national figure. Most of the VHSND session, the coverage of the TT vaccination, it was more than 90%. The registration of the pregnant women, the provision of IFA and calcium supplementation, that was there, but the coverage was not that high. Although the blood pressure measurement was done in the 80% of the VHSND, but if we see the qualitative gap, the distribution of the IFA tablet, that was suboptimal. Ideally, the recommended is 100, but it was approximately 30 tablets which they were giving because of the lack of stock. And weight measurement, hemoglobin, urine estimation, it was there, but it was ranging from 60 to 70% in those VHSND sessions. Basically, the gaps which we identified, it was relating to the logistics. There were non-functional weighing machines, or there were no hemoglobin strips which was available for the measurement of hemoglobin. Because for antenatal examination, we need a proper space with a shield. So that was missing in most of the VHSND session. And there was no toilet for this routine urine examination, because it was mostly a rented premise of this VHSND where the VHSND was occurring. And the landlord or the person who was in charge of that area, he was not willing to share the toilet. abdominal examination, as I have told, it was not possible because of the lack of non-availability of a shield or a toilet in the adjoining area, and the provision of the deworming tablet, it was also not available. If we see the positive finding on the quality of counseling services, although the mentioning of the early initiation of breastfeeding was there in 80% of the VHSND, but if we see the quality, there was a huge qualitative gap. Maternal nutrition message, which was a very suboptimal, it was being delivered in 60% of the VHSND. They were being counseled on few points for the minimum and importance of the minimum antenatal checkup, the factors associated with the iron folic acid intake, the calcium consumption, and the other factors associated with the iron folic acid and calcium. But there was a proactive engagement, which this was an encouraging point which we have observed, that they were trying to involve the decision maker like husband and in-laws, and it was observed in 60% of the VHSND. But again, I said that the quality of the information which was being imparted to them, that was suboptimal. Complete information was not being given. The importance of MCP card and the upkeep of MCP card, and because we know that a lot of information is there on MCP card, that was not being told to the beneficiaries. And related, the in-depth communication related to the diet diversity, the meal frequency, the factors associated with the iron folic acid supplementation, or the addressal of the compliance issue, that was missing. They were not being told regarding the importance of weight gain. Weight was being taken and it was being recorded on the MCP card also, but the women or the beneficiary and the decision maker, they were not very much, they were not knowledgeable, or they were not knowledge being not imparted to them regarding the importance of weight gain and the birth preparedness, because birth preparedness is a very important thing. And these days we talk a lot about birth preparedness, but that was also missing from the counseling. If we see the lactating mother, in case of a lactating mother, there was a complete absence of counseling. That means the front level worker, they were knowing that there's no need to counsel the lactating women. So they were not being counseled on the diet or on the diet diversity. They were not being counseled on the iron folic acid. They were not being given also the iron folic acid and the calcium supplementation for future intake. There was no discussion on the meal frequency and on the side effect of the things which was present there. If we see the status of mother and child nutrition at VHSND, the positive thing which we have observed, that the related to child nutrition, more than 2/3 of the information were giving, they were giving the information regarding the counseling and the child nutrition. And those who provide the child nutrition, they were missing on very much important points, like weight measurement was being taken only in case of a 64% of the VHSND. There was a non-availability of the weighing machine in those places. And if it is there, then it was not functional. The plotting after taking weight also, the plotting of that weight on that growth chart, it was there only in case of a 36% of the children. And screening for the malnutrition, it was there only in case of 45% of the children. And then provision of ORS and this for the diarrhea, it was there only in case of 20% of the children. If we see the qualitative gap of this, then only the Anganwadi worker was responsible for measuring the weight and height, plot the graph, but they were not being supervised either by the lady supervisor or by the CDPO. So there was a huge gap of the knowledge. They were not knowing how to plot it. They were having that tablet with a CAS, but they were not knowing how to perform the plotting of weight chart on that CAS. And although initially there was a non-availability of the weighing machine, but gradually when we have visited, so in a span of 5 to 6 months, At most of the places, weighing machine was made available. If we see the quality of counseling services at those places, exclusive breastfeeding importance was being told to 83% of the women, but for that exclusive breastfeeding, there was no message which was being given regarding the attachment, regarding the positioning of the babies, the common difficulties which the mother faced during the breastfeeding. They were not being counseled and they were not being entertained also. And they were not knowing that if they give water, it is not the exclusive breastfeeding. So they thought that if they give water along with the breast milk, then also it is a exclusive breastfeeding. Counseling on continued breastfeeding was there in most of the cases, more than 2/3 of the cases. And timely introduction was of the complementary feeding was again there for more than 2/3 of the cases. But if we see the quality, then there was no discussion on how to start the complementary feeding, because we know that the baby takes time to adapt to the mode of feeding and the type of feeding. So they were not being counseled on that. There was not they were not being told regarding not to give junk food like packet juice or the biscuits or the chocolates, and there were no discussion regarding the age appropriate consistency and the quantity, because we know that the consistency from 6 to 9 months, it is different from the 9 to 11, and again it is quite a lot different from the 12 to 23 months. So that regarding the consistency, quantity, frequency, they were not being given the specific messages regarding the complementary feeding. If we come to the diet diversity, the counseling on diet diversity, it was also only in case of approximately 1/3 of the women and the children. And importance of weight gain and giving the food during the illness, it was also not being emphasized. They were not being counseled how to prepare ORS during the diarrhea and how to administer that. And the front line worker, they were also not very much knowing regarding the diet diversity, because when we asked, they said, okay, acha khana or tandurust khana. But when we asked specifically, what do they mean by acha khana, then they were not very specific regarding the dietary diversity, the various food groups, and inclusion of the 4 or 5 groups along out of the 10 or 7, depending on whether it is a diet diversity for children or diet diversity for women. So if we see the reason as a whole for non-providing the quality services on MIYCN, then there was a lack of knowledge, because they said that they have not received training. Even not only the frontline worker, even the medical officers, the ANM, they were not knowing regarding the Poshan Abhiyan. Not a single session was held in that particular PHC for this Poshan Abhiyan. So most of them were asking, like ANM and medical officer, that we are a medical professional, how we are linked to the this nutrition part. This is the ICDS work. This is not the work of a health department. So they were not being oriented. That's why all that knowledge regarding the diet diversity and the that meal frequency, quantity, they were not thinking that this is their job responsibility. Seeing the use of job aids, most of the places there was no job aids available, and if it was available, they were not using them. The IC material, if it is there, they were not using them, not pasted posters, although the posters were provided by Alive and Thrive to various places afterwards, and then they started using that. If we see the quality of nutritional counseling, the compliance was not being checked. Like even if they were given the IFA or the calcium tablet, whether they are taking it or not, what the problems were there, whether they are facing, they were not being told regarding that. And again, I have emphasized that the component of diet diversity and the difficulties, the problems which they are facing, that was highly missing from the counseling. If we see the logistic availability, then there was a shortage of the IFA and calcium tablet, the MCP card, and the equipment. Either it was in a non-functional or there was a lack of space and time for counseling. Now, if we come to the MIYCN services and counseling of this community-based event, then we can see that there are two community-based events which we have observed. So one is the God Bharai Divas, which is celebrated on 7th of every month, and the other was the Annaprashan, which was celebrated on 19th of every month. So God Bharai Divas, in most of the cases, more than 90%, the eligible pregnant women, they had been mobilized by the ASHA worker, and updated functional weighing machine and updated due list, it was available. But if we see the quality, then women in the third trimester, they were being invited more than the women in the first and second trimester, because they thought that the third trimester is the most important and the nutrition should be there basically in the third trimester. So they said that in first and second trimester, there is no need for all this. And again, the type of diet diversity, the food types, they were not kept. Mostly what they did, they just kept fruits of various types. And they said that this is diet diversity. So by keeping only the fruits, they were thinking that by giving the 5 types of fruits, we can have out of 10, we can have 5 type of food group. So they were confused regarding the type of diet diversity. Again, in case of, if we see the logistic, because it is a few people from the community, they are also being invited for these community based event. So sitting arrangement was not proper in that VHS, in that God Bharai Divas. Availability of logistics like mat, it was absent in 50% of the event. And they complained, Anganwadi worker complained that they have not received the funds for this celebration. So they are spending from their own pocket. So we have given this feedback to the ICDS director, and later the funds were mobilized, and later this problem was overcome. Regarding this appropriate IC material with the appropriate this supportive supervision also, it was made available to them and they started using that. If we see the quality of MIYCN counseling, the importance of antenatal visit and the information related to Pradhan Mantri Matri Vandana Yojana and Janani Suraksha Yojana, it was discussed in 75% of the event. Importance of weight gain and IFA tablet, that was again, it was suboptimal, 63%. Diet diversity and the meal frequency, the importance of iodized salt, that was only being told in the 50% of the event. And discussion on importance of early and exclusive breastfeeding, that was there in 50% of the event. How to ensure the diet diversity using the locally available food, that was largely missing from all the community-based events, and they were not discussing the compliance issue, and again the trimester-wise frequency of meal and the proactive engagement of this proactive engagement of the mother-in-law and the husband, it was there only 25% of the cases. If we see the organization of Annaprashan Divas, because Annaprashan Divas is celebrated for starting off complementary feeding. So functional weighing scales was there in 73% of the event. Reporting format was also present. And they had a updated list of all eligible children, but attendance was not very much large at that point, where very few people were present. And they also complained the same thing regarding the non-availability of fund. Relevant IC material, it was displayed only in 23% of the event. And again, there was a problem with the display of the diverse food group. And mat and safe drinking water facility was there only in 45% of the event. And there was no refreshment which was served to the participants. So gradually, because the participants, they were expecting some sort of refreshment, but since fund was not there, so that was not provided to the participant. If we see the counseling, the quality of counseling during the Annaprashan Divas, then Anganwadi worker, they were informing mothers only like continuity of this breastfeeding till 2 years. But again, they were starting that how to give the food, demonstration of that complementary food, the frequency and the age appropriated food, that was largely missing. And that limited focus on the responsive feeding or the active feeding was there. And it was also the involvement of grandmother and the father was suboptimal for this counseling services of Annaprashan. If we see the reason for non-provision of quality services on MIYCN during these community-based events, regarding knowledge and skills, 1/3 of the Anganwadi worker, they mentioned that the incremental learning approach module, they have started with that, but most of them, they have not finished that. And in that also, they said that they were not being told how to plot the weight on the growth chart. They told that they don't know about the maternal diet diversity. They have not been told regarding what are the points. It was not a checklist based. They have not being told regarding the side effect of iron, folic acid, calcium supplementation, the meal frequency, quantity, and consistency of the complementary food. And this problem solving and coaching, because there was no mentoring from the side of CDPO and lady supervisor. So it was largely the Anganwadi worker. Whatever they are doing, they were not being mentored by their higher level officials. The posters and IC material that it was
just last 1 minute. Maybe you can finish your session.
Okay, so job aids, either it was not available, or if it is available, they were not using it. And there was a problem, like we see in all other programs also, there was a problem with budget availability in organization of these community-based event. And Anganwadi worker, they have to spend their own money from their own pockets for organization of these community-based event. The other issues which were identified, that the women were occupied with the household chores, so they were not very much willing for this CBE, and the primary gravida women, because there is a social taboo that they should not be going, so they were not going. And participants, like we have discussed, that they expected some sort of benefit or refreshment from the organizer side. So I am done, because from now onwards, Dr. Tanu will be, so I am stopping my screen sharing, and then Dr. Tanu may start sharing her screen.
Before you do that, I would like to give my comments. The Pragya,
yes, sir.
Your presentation was excellent, spellbounding,
Thank you, sir.
hypnotic. Dr. Arun Srivastava, I think your father-in-law, if I will say so, was Dean of the BRD Medical College in Gorakhpur way back in 1980s. I was doing a project on iodine deficiency disorders in that part of the Western UP, Eastern UP. So there I met a psychiatrist, psychologist by the name Lal Bachchan Tripathi. So Pragya, what you signify, what you presented today was excellent dialect, diction, deportment, and delivery. Superb.
Thank you, sir.
I just want to make one more comment, that we have to increasingly focus on behavioral sciences, sociology, anthropology, psychology, economics, and psychology. And this tells us why things are happening the way they are happening. So Alive and Thrive team, once again, most grateful to you for introducing this new dimension in terms of trying to understand the ground realities so that corrective action can be taken. Numbers are important. They are necessary, but not sufficient. So Pragya, next time you appear in any presentation, this time I'm giving you 10 out of 10. But next time, if you want to get 12 out of 10, then only I'll change the session. Thank you very much. Carry on. Excellent work. I think we should all stand up and clap for these youngsters. Superb. Seventy, I am going to gild the lilies. Lilies are such a beautiful flower. It does not require to be gilded. But I think I'll step into this presentation and share the session only when the lily has to be gilded. Thank you very much. Congratulations. Deep appreciation. Cause for celebration. Excellent. Excellent.
Thank you.
Thank you, sir.
Thank you so much, sir. Thank you.
I can see on the screen there are two questions from Dr. Sunila Gar. What was the minimum time spent per woman? So the minimum time spent was 25 to 30 minutes per woman, because it was a mix of a qualitative tool and a quantitative tool. And in that antenatal women, regarding that Godh Bharai Divas, only those women who were invited, they were there. But the women who were not invited, there was some sort of dissatisfaction in the rest of the pregnant women and the mothers of those women who were again in that eligible group. And the role of A&M was again in that the role was mixed, because in CB mostly the role of A&M was not that much. It was basically the Anganwadi worker, and mobilization was done by the ASHA. Yes, ma'am, you are right that counseling is not the term which we should be using, because counseling is entirely a scientific term, and we know what is the component of counseling. But here, obviously, we are using it loosely with the education. So you are right in your statement, and quality can be scored. Yes, right now we have we made repeated change in the tools also, and there we planned for a continued project based on this topic only. But since lockdown was announced, so we could not continue with the measuring the quality. So that was that we missed out on those points.
Thank you, Pragya. Nice seeing you. And I was wondering which Pragya it is, After Alipur, I'm seeing you now. Thank you so much. Nice.
Yes, ma'am. Same here, ma'am. We are meeting after, I think I left MAMC. I think after that I'm meeting.
Yeah. And that's I met yesterday Meera. I had gone for interviews there.
Okay, ma'am. Good to see you, ma'am.
Yeah.
Okay, so now I will invite Dr. Tanu Mida for her presentation. She is professor and head department of community medicine, GMC Kannauj, and she's really a dynamic person, highly motivated and always on toes for project related activities. She's a member of editorial board of World Journal of Meta-Analysis, and she's an associate editor of the Journal of Preventive Medicine and Holistic. And she has been engaged with various projects with various government and international NGOs like UNICEF on different aspects. So, and she had won Dr. Deepak Banerjee Award for a best paper in 2011. So, welcome, Dr. Tanu Mida. Over to you.
Thank you, sir. At the outset, I would like to congratulate the Alive and Thrive and IAPSM team for organizing such a wonderful conference, such a wonderful online event for the first time. And we hope this is just the beginning and there are many more such events to follow. And thank you, Dr. Pragya.
I would request you to be aware of the timeline. Yes, thank you.
Is my screen visible?
No, please share the screen.
Yeah, I'm sharing the screen, but
it's just started. Yeah.
Is the screen visible?
No, I think.
Dr. Tanu, open the presentation first, then try sharing screen.
Okay.
You close the screen.
First open your presentation, then try sharing screen.
Yeah, I've already opened the presentation.
Then click on share screen and then select the presentation. Now it should show.
Yeah, got it. Yeah, is it visible now?
Yeah, it is visible now.
Yeah, thank you. Thank you, Dr. Pragya, for highlighting the methodology of the project and for sharing some of the findings of the project. Now I will continue with the remaining findings. Actually, we had done home visits and we had interviewed pregnant women and mothers of children less than 2 years. So there we had collected data regarding the counseling on MIYCN, which these pregnant women and mothers had received during home visits. So our findings were the positive findings, the encouraging findings were that all these pregnant women had been contacted by frontline workers at home in the last 3 months, mostly by ASHAs. And around 44% had been contacted by Anganwadi workers and 89% by ASHAs. The frontline workers had mobilized these pregnant women to attend the community-based events in 90% of the cases. And these frontline workers had also counseled the pregnant women on early ANC registration, minimum number of ANC visits, IFA consumption, and calcium supplements. However, the issues were that they had not been able to address the IFA compliance issues. They were not being able to address the mother's concerns regarding side effects of IFA. What was lagging was that only 37% of the pregnant women had received counseling on weight gain during pregnancy. So most of them were not aware how much weight should be gained during pregnancy, and the Ashas and Anganwadi workers were not able to satisfy their queries regarding the same. And only 1/3 of the pregnant women had received counseling on maternal diet diversity, quantity, and frequency. Like Dr. Pragya has said, these workers, when they visit the pregnant women, they just tell them, hari sabjiyan khao, doodh piyo. They don't quantify how much food should be taken, the frequency at which it should be taken, the amount that should be consumed, and regarding the 5 food groups. So that is why these pregnant women were largely unaware about what kind of diet they should be taking. And that is why the maternal nutrition was a not very well addressed issue during counseling, during home visits. The qualitative gap was that no detailed discussion on recommended diet diversity was done, and also not regarding the meal frequency and quantity. Now, regarding the counseling of mothers with children less than 6 months, the positive findings were that most of these women had been contacted by frontline workers during the last 3 months, mostly by Ashas and also by Anganwadi workers. Immunization due date was also discussed during these home visits. So primarily these home visits were carried out with the motive of immunization only, regarding mobilization of pregnant women for TT vaccination or mobilization of children for immunization. What we emphasize is that these visits should also focus on the nutrition aspects, which was largely lacking. These mothers had received messages regarding exclusive breastfeeding and timely introduction of complementary feeding, but this was only 58%. It is progressing, however. 50% had also received support from frontline workers on correct positioning and attachment for breastfeeding. The quality aspects were that they did not know when and how to start complementary feeding. Like at what age it should be started. Some of them were also saying that it should be 8 months or 9 months. They were not very clear regarding the exact age of starting complementary feeding and how exactly it should be started, what should be the consistency of the food that should be given, and the food frequency and the quantity. They were not very well aware. And then the mothers were not even discouraged from using bottle feeding and powder milk. Some of them were actually using bottle feeding. What was lagging was that 38% of the mothers received message regarding no water to be given during breastfeeding. The concept of exclusive breastfeeding says that we give only mother's milk, no water, and apart from mother's milk, that the only thing that is allowed is medication prescribed by some doctor. But here we found that the mothers were giving water along with mother's milk. So this was a counseling issue, that the Ashas and Anganwadi workers were not being able to counsel the mothers on the concept of exclusive breastfeeding, that nothing else has to be given. Then counseling of breastfeeding during illness, this was also lacking. The mothers were discontinuing breastfeeding during illness. And we told them that they have to continue breastfeeding, but they were not very convinced because the Ashas and Anganwadi workers had not told them already. Then there was limited focus on breastfeeding difficulties and problem solving during breastfeeding. Then the use of job aids while counseling about exclusive breastfeeding was minimal. It was only 29% because probably they did not have job aids. And when we asked them whether they have it at their center, so they denied that they don't have any such job aids to counsel the mothers. Then diet, IFA supplementation and calcium supplementation for lactating mothers were not being discussed. IFA and calcium is being given to pregnant mothers, but regarding lactating mothers, this is a big issue. Then regarding counseling by mothers, regarding counseling of mothers with children 6 months to 23 months of age, the positive finding was that these mothers were being visited by Ashas and Anganwadi workers and were being mobilized to attend the community-based events. The mobilization part of our system is strong, like whether it is for immunization or it is for community-based events, the mothers are being approached and they are being mobilized. But the counseling part is very weak. Like they do go to their home, but the visit is not properly utilized as it should be. Then this is progressing. Counseling on timely introduction of complementary feeding, this is 61%. 68% of the mothers are receiving counseling on continued breastfeeding, and 64% of the mothers are receiving counseling regarding hand hygiene and sanitation. The qualitative gaps were they were not aware about the correct age of introduction of complementary feeding. Then what was majorly lacking was that the mothers were not aware about the diet diversity, that the child has to be given 4 food groups, the meal frequency, how much food a child 6 months to 8 years, 6 months to 8 months will be given, and 9 months to 12 months, and 1 year to 2 years. There are different categories, and accordingly the frequency and amount is different. So they were not aware of that. And when we questioned the Ashas and Anganwadi workers, their knowledge was also very scarce. They were not able to quantify exactly how much is to be given. They just say khichdi de do, dal ka pani de do, and dal ka pani is also like we are supposed to give them dal. The consistency should be thick, and they say dal ka pani. So the food frequency and the consistency is not what it should be. Then the counseling regarding vitamin A supplements, IFA, deworming, and feeding during illness, this was also suboptimal, around 32%. And again, the use of job aids by the frontline workers was very minimal. It was only 11%. The qualitative issues were that there was non-availability of IFA syrup, and the counseling on IFA doses and compliance issues was largely lacking. Now, the reasons for non-provision of quality counseling, what we identified, the major reason was lack of knowledge and awareness. Even the ASHA facilitators and the ICDS supervisors were not able to tell us about the correct frequency, correct quantity, and correct diet diversity. So when they are not aware, what will they supervise and mentor the frontline workers? And these frontline workers were also largely unaware. And this is a training issue that maybe we need to organize refresher trainings or sensitization workshops or something where we can brush up their knowledge regarding these issues, because they are only 8 past, so maybe they tend to forget. But if we re-emphasize, then maybe our message will reach the beneficiaries. Now there was lack of knowledge regarding maternal diet diversity, gestational weight gain, IFA side effects, breastfeeding difficulties, complementary feeding, frequency, quantity, and diversity, and even growth chart plotting. The Anganwadi workers were not able to plot the weights on the growth chart, and even the Ashas were not able to do so. The ANMs were knowing, but then they were so busy with the antenatal checkups and stuff like that, so they are not largely available for counseling. IFA supplementation in young children counseling was also lacking on this aspect. Regarding logistics, there was non-availability of job aids for counseling on MIYCN. These quality gaps in nutrition counseling, they are again a training issue, which I've already discussed. And regarding logistics availability, IFA and calcium supplements for lactating mothers were not available. And IFA syrup for young children was also not available. Now, supervision by frontline workers. This is another missed out aspect, but we found that in our district, it was largely being done. The supervision was being done, but the quality of the supervision was not up to the mark. Then these key findings were obtained from interviews with ASHA facilitators and ICDS supervisors. We found that the positive finding was that more than 70% ASHA facilitators had a route plan for supportive supervision visits, and they were largely following it also. 86% of the ASHA facilitators were aware about the responsibilities related to monthly meetings of ASHAs, and they were organizing it very regularly. And they also provided guidance on gaps identified during home visits and during VHSNDs. Then 86% of the ASHA facilitators were familiar with the incentive list, supervisory checklist, and reporting formats. All ASHAs shared that the ASHA facilitator organized monthly meeting for review and planning, and any problems faced by the ASHAs were directly addressed by the ASHA facilitators. ASHA facilitators also supported the ASHAs in enlisting all pregnant women and 0 to 2 years children. 86% expressed that these ASHA facilitators addressed the grievances of ASHAs immediately by reporting to the appropriate authorities, and also ensured timely payment of incentives. What is progressing is that 57% of these ASHA facilitators were attending meeting with the block nodal officer, block community mobilizer, and they were also instrumental in organizing community meetings. And they were also now attending village health, sanitation, and nutrition committee meetings. What was seriously lagging was that they had little knowledge about how to maintain the ASHA's drug kit. Regarding the date of manufacture and expiry of drugs, they were not very familiar and not being able to do this task properly. And the liaising with Panchayati Raj institutions was not very good. It was okay, but only 29%. Regarding ICDS supervisors' roles and responsibilities, the positive aspect was that they visit Anganwadi workers every month and provide them feedback. They guide Anganwadi workers in weighing the child correctly, plotting it on the chart, and identifying the at-risk children and referring them to the appropriate health facility. Then they also check the enlisting of beneficiaries, particularly severely malnourished children. They also arrange for storage and distribution of food and take-home ration and registers and report all the shortages to the CDPO. They also check for availability of logistics and equipment like functional weighing scale, infantometer, smartphone, internet connectivity, etc., and ensure that these things are available with the Anganwadi workers. They also conduct sector and cluster level review meetings and discuss the issues and provide feedback, which definitely improves the service delivery. Then regarding the health supervisors and the block medical officers, we had done in-depth interviews with these people themselves, and then these are our findings. The positive finding was that the block medical officer conducts review meetings every Tuesday with ANMs and monthly review meetings with the BPM and BCPM. A regularity of these meetings is a very good feature, but the topics discussed in these meetings are largely immunization, institutional delivery performance, JSY disbursements, and administrative issues. Nutrition is not very much on their agenda. Poshan Abhiyan is not taken very seriously. So what we need to emphasize is that during these monthly meetings, nutrition should be on their agenda, and a sort of sensitization can be done for the ANMs to brush up their knowledge on what issues they have to address, and the same knowledge should be percolated down to the Ashas and Anganwadi workers. Then planning of trainings of frontline workers is also done during these review meetings. Now, a summary of findings and actions for consideration. I will take it point wise. Regarding training of frontline workers, we need to focus on these topics: maternal diet diversity and trimester wise quantity and meal frequency, management of side effects of IFA, weight gain in pregnant women, IFA and calcium supplementation during postpartum period, which needs to be highlighted. During the antenatal period, it is being done, but during postpartum period, it is not being taken very seriously. Diet diversity, quantity, consistency, and meal frequency for complementary feeding. This area needs to be addressed very seriously because this is where malnutrition starts in the children. So if we can address this issue, then mostly we will not have our children landing into the yellow or the red category, and we can save them. We don't have to go for referral. We can manage them at home only. Addressing breastfeeding difficulties, feeding during illness and responsive feeding, and child's weight measurement, use of growth chart, detection of growth faltering, and identification of malnourished children. Then IFA supplementation in young children. Regarding supportive supervision, we need to strengthen these aspects, that the microplan for supportive supervision should be available and they should be followed. Then there should be a supervisory checklist with focus on MIYCN parameters. They have a supervisory checklist, but that largely focuses on RI. So the only nutrition aspect that is there in it is vitamin A. So we need to develop another checklist or maybe add on to the existing checklist so that while supervising their frontline workers, these supervisors can focus on MIYCN parameters and check them if counseling is not being done, or if IFA supplementation is not being done, or if weight gain during pregnancy is an issue that is not being addressed. So if we can just improvise on that supervisory checklist, maybe we can go a lot forward in the terms of maternal and child nutrition. Then orienting supervisors to focus on mentoring and on-job coaching, strengthening block level review meetings to prioritize review of MIYCN service delivery. Like Poshan Abhiyan should be on the agenda of these monthly review meetings so that we can sensitize these ANMs again and again, and they can go down to the block and sensitize the Anganwadi workers and Ashas. Then regarding availability of equipment and logistics, as Dr. Pragya pointed out, functional weighing scales are not available, and we have reported this issue at the state level also, and hopefully we will see some improvement in the future. Hemoglobin testing kit is also an issue, but not to that extent. IFA and calcium supplementation for pregnant women and lactating women, it is short in supply. Like Dr. Pragya said, instead of 100 tablets, they give only 30 tablets. But this issue also needs to be addressed. Then IFA syrup for young children, this is also in short supply. Now, actions which have already been facilitated at the district and state level through quality monitoring by a medical college facility, I need to highlight this. This is like what we used to do. We used to give on-site feedback to the frontline workers, that is Asha and Anganwadi worker, to their supervisors, to the block medical officer and the CDPO. And these findings were shared every month with the CMO and with the DPO ICDS for action in both the districts. And these findings were also shared at the state level with Director ICDS. Now, what improvements we were able to bring about Instructions were sent to the medical officers of all the blocks by the CMO Kannauj to sensitize the health supervisors, ANMs and ASHAs on Poshan Abhiyan activities during the regular monthly review meetings. And on request of Medical Officer Jalalabad Block, the faculty of GMC Kannauj had personally oriented ANMs on Poshan Abhiyan activities during one of these monthly review meetings. One good thing that we were able to bring about was that we were able to organize a one-day complete training for Anganwadi workers from Block Tirwa at GMC Kannauj on 19 November 2019. Here, 76 Anganwadi workers had participated along with their CDPO. Here we had taught them, we had demonstrated how to take measurement of weight of children, plotting on growth chart and classification of malnutrition. And we had also provided the information, all information regarding age appropriate counseling, regarding complementary feeding, that is quantity, frequency, diversity of food to be given to children 6 months to 2 years. The CDPO herself emphasized to the Anganwadi workers that they were supposed to use this data to counsel the mothers on frequency, quantity and diversity of complementary feeding to be given to 6 months and 2 years old children's mothers during Anprashan Day. So as a result of this, what we were able to do before this training, when we used to visit the field on the Anprashan Day, in their registers, Anganwadi workers record their findings. So earlier they used to just write that on this day, Anprashan Day was organized and a child who had turned 6 months, he was given kheer for the first time. This was the event that they used to do. But after this training, in their registers, we could find that they had mentioned age-wise. 6 months to 8 months child has to be given half katori food for 3 times a day. Then 9 months to 12 months has to be given full katori 3 times a day with snacks. 1 year to 2 year child has to be given full katori with 3 times a day with snacks. So they were able to actually quantify how much has to be given. So when they were recording it in their register, probably they had given that counseling to the mothers also. And this would be visible in the field also. Like we were not able to analyze the data, but we could see that from the monthly register that the weights of children earlier, they were in the yellow category, and within 2 to 3 months they had converted into green category. So this was one beginning, and we hope that in the project later on we can continue with this and maybe get some fruitful results in the district. Then CDPOs of all the blocks have instructed the ICDS supervisors to have refresher sessions with Anganwadi workers with respect to maternal diet diversity and complementary feeding in children. Then at Muzaffarpur also action had been taken at the district level in all the 4 blocks where quality assessment visits were made. The MOICs and block community mobilizers have been instructed by the civil surgeon to improve home visits by ASHA and review the content and coverage during monthly meetings. In all the 4 blocks, block level orientation had been conducted for ASHA facilitators and ASHAs on IFA and calcium supplementation counseling, including ensuring compliance for pregnant women. Then at the state level, the state nodal officer Poshan Abhiyan instructed DPO Muzaffarpur to ensure availability of functional weighing machines in all Anganwadi centers. This is a very positive sign. Then the state ICDS director had also taken cognizance of the non-receipt of funds affecting organization of CBE events, and the process of reimbursement is being streamlined. Decision has been taken to conduct training needs assessment of CDPOs and ICDS staff to improve the services being provided during the CBE events. And retraining of all the ICDS staff on ILM modules is being considered, and also monitoring of CBE activities through development partners using a checklist dedicated to Poshan Abhiyan is being replanned. So this was all that we have done so far, and we hope that in future we have many more things to do and much more will come up so that we will bring about a distinct change in the districts with respect to maternal and child nutrition. Thank you.
Thank you, Dr. Tanu and Dr. Pragya. I would request if chairpersons have any comment on these presentations and their views on it. Okay, Dr. Tanu, I think this was an excellent presentation from you, both of you, Dr. Pragya and you. And really, this has you have highlighted the various quality issues in terms of delivering services, not only service, but other enabling supporting factors, supporting enabling structures, you can say, apart from just actual services. So this is important thing for the next level of implementation. And there was one question from Dr. Arun Agarwal sir. We need to move to the next step for this assessment. So do you like to address or
Sir,
what
actually, we
will be
need.
the next step for this?
Good morning, sir. Thank you for the question. Sir, actually, in the next step, we are going for a scale up. We have already 2 districts in UP and 1 district in Bihar, where we will be continuing these activities. And as a continuation to this project, we have got sub projects where we are planning to do this only, that we will take up a pilot in a sub district level, and there we will educate and train these Anganwadi workers and see the difference that is brought about in the field. We'll do a baseline survey, and then after training and retraining of these Anganwadi workers, then in the follow-up months, we will see what improvement has been made in the category of malnutrition of the children. This is what we are planning so far.
Yes, thank you. So you have highlighted that based on the assessment, whatever the gaps you identified, some priority gaps will be taken as a sort of small projects, like to see that it is implemented sub project as it and provide support to the system to get it implemented in a logical sequential process of rigorous process of documenting and implementation, right?
Yeah.
Okay. Yeah. Thank you. Thank you very much for your presentation. These were excellent presentations. So, any last comment from chairs for this session, sir? Mandav sir.
Yes, I just want to say that I'm seeing superstars. Superstars in action. Give them a big cheer. All of them. Superb.
Thank you.
Now you have the responsibility, 2 things. Make your students smarter than you.
Sure,
Number 1. And make the clinician colleagues of yours, try to make them smart. They think they're smart, but just trying to make them smart in terms of public health orientation. These are 2 important messages I want to give. Very good.
Sure, sir. Thank you so much, sir. Thank you, sir.
So thank you. This was really an excellent presentation, giving an insight on what this quality assessment is, quality aspects are there in delivering nutrition programming. Now, with everyone's kind permission, now we are moving to the next.
Kailash, I just want to say one thing. Today is the first day of Navratri, and I can't think of a more auspicious day in my faculty performing so well, exceedingly well. तो माता का आशीर्वाद है सबके लिए, माता का आशीर्वाद है.
Yes, exactly. Okay. So now we go to the next session, which is also another aspect of MIYCN integration that we will be talking on, which is on integration of maternal infantile nutrition in the undergraduate curriculum. And I think this is an important component for the community medicine faculty also for the future generation of doctors, so that we create a champion future ready doctors. So now for this, I would like to invite our first chairperson for this session, Dr. Surekha Kishore. She is the executive director from AIMS Gorakhpur, and she had a vast experience of in teaching and training on medical and paramedical and non-teaching staff on different health aspects. She had participated in various international and national projects and various intramural projects, and her presence had been seen contributions in various conferences. To her kitty, she had almost 70 papers being published. She has received many national awards and almost 80 articles in various journals. So welcome Dr. Surekha Kishore ma'am for chairing this session. I would like to also invite our second chairperson, Dr. Dinesh Badiyal. He has contributed significantly to new competency-based UG medical curriculum in India as a member of Reconciliation Board of Medical Council of India. He is the Program Director, CMCL, FAI, MER Regional Institute, and he has been the convener nodal center for faculty development. So his profile is very interesting, and his overall work, most of the work had been around the curriculum and education of the doctors and other things. He had also received fellowship by the FAIMER from Philadelphia, and had received awarded by MHP award from Yale University. So I welcome Dr. Dinesh Badial to chair this session, next session. And I would request you to invite our speaker for the session.
Okay, we begin with this session on MIYCN integrated curriculum, and a very warm welcome and good afternoon, good morning to all of you. And I would like to first of all invite Dr. Ramba Pathak, and she is the Dean, Government Institute of Medical Sciences, GIMS, Greater Noida, UP. She is Professor and Head Department of Community Medicine, GIMS, Greater Noida, UP, Executive Member of MIYCN, National Working Group of IAPSM, Expert Group Member for the MIYCN e-learning program at IIPH, Delhi and PHFI. She is also life member of National Academy of Medical Sciences. So let us listen to Dr. Ramba Pathak with such a vast experience, and I hope it would be a very good learning and sharing of experiences with her. So Dr. Ramba Pathak, we welcome you for this session. Madam, please unmute yourself.
Unmute.
Okay, thank you everyone. Thank you, ma'am, for the introduction. And basically, I'm very happy to see that we have 342 participants who are here to listen to our talk. Every time, this is a very good platform to disseminate the work that we have done. And now I would like to share my presentation. Is it visible?
Yeah, visible.
Yes. So first of all, I would like to thank
slideshow mode.
The organizers. Okay, yeah, I'll enter it into slideshow. Is it visible?
Yes.
Yeah. Okay. Thank you for providing us the opportunity to share this information. And I would congratulate IAPSM and Alive and Thrive for creating this opportunity. In 2018, when we had this MIYCN working group, which was formed for, we started looking in areas where we can work and bring out result. So as academicians, the first thing that came to our mind was, if we want to address malnutrition, we have to catch future doctors. We have to improve their knowledge acquisition regarding nutrition. If it is done in an integrated fashion, then once they will practice, they will do it that way. So basically, the whole purpose of developing this curriculum was to make them gain knowledge in an integrated way and then deliver it accordingly. We also had, along with this, we also had service protocol, but that was done by the clinical departments. And in this, most of the thing that we did was basically we had faculty from 4 medical colleges in UP and Bihar, along with Hamdard Institute of Medical Sciences and Research, which also participated, and we made deliberations, we had discussions, and then finally we came up to a curriculum, and this was all being done in 2019. But at the same time, if we remember what happened was the medical education system was undergoing a change. And we had this CVME which came up. So we got an opportunity to align what we had developed in the form of a competency-based medical education curriculum. And then we could see that it was feasible and it is possible for medical colleges to adopt it. So I would basically have this discussion on 3 points. First of all, the process of development of curriculum, how this curriculum was prepared, because that would show the validity, what all things were basically considered while preparing it. Then what are the salient features of this curriculum and what is the feasibility of implementing it? Now, before planning this, curriculum, we did gap assessment. And while doing gap assessment, we had some observations, which I would share with you. Then we did the data analysis, the analysis of the competencies that were given under CBME. How many competencies are there related to maternal, infant, and young child nutrition? What are the core departments which are involved? Then how many number of hours that has been assigned? All these things were worked out. And we prepared facilitators guide, which is for faculty members, and also prepared technical module for students so that it is easy for them to get everything at one place. And then we also prepared model PPTs for interactive lectures so that we can have a standardized curriculum throughout the country. Now, when we did gap assessment, what we saw that in the previous curriculum, whatever the way it was being taught and the things that were being covered was more or less similar to what has been proposed. Only the methodology has changed. In the previous curriculum, what we saw was 17%, like these are the different departments, community medicine, OBG, and pediatrics. What we saw in community medicine department in existing, 17% of it was being covered in theory and 14.5% in practical. And as per the proposed new curriculum, it was 20% in theory and 15% in practical. And in OBG, we could see that there was a change because maternal nutrition was not earlier being taught by OBG department in that much detail. But now under the new curriculum, we could see that 8% has been proposed, and even in practicals, from 6.9%, it was increased to 12%. And in pediatrics department, it was 10%, and the proposed one was 12%, but the practical was being covered well by the previous curriculum too. In the assessment, when we started seeing what all was being done in theory and practical, we could see in community medicine, 17.5% was being asked in theory and practical portions of the exam. In OBG, it was only 5%, and in pediatrics, only 12.5%. So once we saw the curriculum, we proposed, this is something that is not given in CBME, but this was a proposal from our side that it should be increased in community medicine to 20%, in OBG to 12.5%, and in pediatrics to 15% of the total assessment that we are doing. And this should be prefixed, this should be decided beforehand that these are the things that are going to be included related to nutrition in our assessment. Now, the salient points of the curriculum that we have developed is, we have basically outlined the competencies which are to be covered in theory and practical, and we have clearly stated which subject will be taking what and how that alignment and integration will be done between different subjects. The core subjects that were there for delivering MIYCN was community medicine, pediatrics, and OBG. So mainly these were the three departments. There were other two departments, biochemistry and general medicine, which were basically coming in the nutrition part, the general nutrition part that is taught, and the elderly nutrition and other aspects are being covered in general medicine. So when we prepared the curriculum, we have taken care of that too, but our maximum emphasis is on community medicine, pediatrics, and OBG related MIYCN curriculum. And we have also included the specific learning objectives, teaching learning methods in each objectives, like what can be done in theory, how it can be done better in practicals, then what are the various assessment methods, what is the mix that can be used for assessing these topics, and the skills to be learned and practiced during internship that has also been included in the module that we have developed. Now, when we did the analysis, what we found that on MIYCN, we had total 80 competencies. And in pediatrics, there were 49 core competencies with 20 integrated competencies. In community medicine, we had only 6 core competencies related to MIYCN, and 14 integrated competencies were there, which were to be integrated with pediatrics department or OBG department. And in obstetrics, we had five core competencies and 10 integrated. So we can see over here that good number of integrated competencies have been used here to deliver this MIYCN program. Now, in theory, we had in total 38 sessions, and which were to be taken. We have seen that the theory part, the lecture part has been actually reduced, and it has been given to small group discussions where we feel that we can teach the concept better to the students. So in pediatrics, there were 12 lectures of 1 hour duration and 8 small group discussion. In community medicine, there were 5 lectures plus 8 small group discussions, and in OBG 3 lectures and 2 small group discussions. What is there in our module is that all these lectures, the topic that should be covered in the lecture, the topics that should be covered in small group discussions, and how it is to be the logistics have also been discussed. What are the things which are needed, the preparations which are needed by the facilitator before starting the classes, because many new teaching learning methods have been introduced. So how that will be done, all that has been given in the guides that we have prepared. And in practicals, there were 42 sessions with 24 practicals in pediatrics, 13 in community medicine, which were mainly in the community setting, and 5 practical sessions in OBG. On integration, as I have mentioned earlier, there were 14 competencies with pediatrics and community medicine. There were 6 with OBG and pediatrics, and there were 4 for OBG and community medicine. So these were integrated topics, which this was something that we analyzed and we found out from the curriculum of CVME that was given to us. Then we decided on when and how to teach. So the core faculties were 3 departments, but medicine and biochemistry has also been given some part of it, the biochemistry part of nutrition. So when we have prepared module, we have included wherever the integration is needed with them. But when we are talking about MIYCN, we have basically highlighted mainly the 3 departments which are delivering this curriculum. Then we have to start it in second phase and try to teach simultaneously and integrate vertically. And we have to see to it that we do both formative and summative assessment. Now, this is the facilitators module. I've just given, I don't think it's very clear, but over here we have written everything, what needs to be done, and even the specific learning objective, where it is there in CVME, which competencies are being addressed from which department. Like you can see the summary page where everything is clearly stated, when it is to be taken, in which phase, which semester, what are the classes, when it would be theory, how many theory lectures, what will be the specific learning objective, what will be the teaching learning method. Everything has been even, and all these new teaching learning methods which have been prescribed by our CISP, Curriculum Implementation Support Program, that has been included. Like for cognitive domain, we have this interactive lecture, then student seminars, small group discussion in the form of, we can have flipped classroom technique, group discussion, reflection, writing, medical quiz and debate. So while preparing that module, we have given topics which can be covered under this. While making presentation, I will show you some topics which we have covered, but other things are given in great detail. Clinical or practical, like for covering affective and psychomotor domain, even clinical social case reviews, what are the scenarios that can be taken in Department of Pediatrics, in OBG, in community medicine, that we have given, what are the problem-based learnings that can be exercises that can be discussed with students, what are the videos that the department should have and the faculty should be prepared with while taking these small group discussions or while taking practical classes, that is also stated. Then for and there are some videos which have been shared with by Alive and Thrive. They have been actually our technical support group, and they have the one who have actually help us in developing this curriculum. So they have shared this video practical from field. They have these videos. They have then We have taken even the clinical demonstration, what are the topics that can be covered, what are the different cases, what can be covered in role play, then what are the field visits which are required in order to bring home the concept of MIYCN. So everything has been very clearly stated. Now, in group discussion, for example, like I would say that what we have done, we have given such scenarios. I'm giving an example of community medicine here because most of us are from this discipline. Like, why is it important to promote adequate feeding for girl, infants, children, and adolescents, and for women? Now we would ask students to write the answer on a flip chart and discuss. And for that, the teacher should be ready with flip chart. So what are the logistics which are required? What should be the venue? How many students should be accommodated? What all preparations are needed? That is clearly mentioned. I will show you just one photograph of that page. Present the intergenerational malnutrition drawn on a flip chart. So we would ask students to present it by making it and then facilitate discussion. The teacher will facilitate discussion in plenary session. So this way students will be involved. It will not be just that one side we are going on delivering and they are not understanding what they are going through. So the best thing is this will basically help in involvement of students and improve their participation. Suppose for reflection writing, we can ask them to write state of maternal nutrition in India and government sources for the same, what happened, and they have to basically comment on so what and what next. So they will go, they will work on it, they will write, and then they will have discussion with the faculty. So this way, since what we have seen most of the time, when we are teaching them these theoretical things, it was like one-sided, the teacher was going on saying and the students were not receptive at all. So these topics have been put in such a fashion so that their involvement will be more. Like in flipped classroom technique, what we can have, we can ask them to study this assessment of nutritional status of mother and child. What happens whenever they go for clinics? They are taught this in pediatrics department, in OBG to some extent, they start telling them how to see antenatal cases, assess their nutritional status. Then in community medicine, we again do. So what we can do is, whatever they have learned from different departments, this will give them an opportunity to integrate the whole thing and then come and have discussion with us. This will also help us in understanding whether they have learned the right thing and whether if there is any discrepancy between different departments, that can be also sorted out. Then for role play and video demonstration, nutritional counseling, breastfeeding, this can be, we should have videos, we can show them, and this will help and improve their knowledge and understanding of the topic in a better way than what we do in PPTs. Then for student seminar, we have done it in the previous institute. I was at Hamdard Institute of Medical Sciences and Research. There we had student seminar and we had given these topics to students for presentation, and we saw that it basically improves their participation, and it also improves their interest in the subject. So the topic that was given was policies and legislations for promoting maternal nutrition. But whenever we hold these seminars, what we have to be very particular about is the planning of the session should be good. If the planning is not good, then it will be delivered and it will be not taken seriously by the students. So what we did in the beginning itself, we told them that 4 to 5 students will be assigned topic prior to 15 days. And they will be aided by their mentors that were assigned, and they can suggest them the textbook, links, specific research article that they can consult, and they need to come well prepared and present it. And then there will be question answer, there will be discussion, and this will give them a detailed insight of the present scenario and the work in progress, challenges, and the pathway to future. So we will be having good discussions. And these days we know that students, they are very intelligent, they're much better than what we were as students, and they are ready to participate. And if we involve them more, the learning will be better. Now for assessment, we have, because it is not only we have seen in CBME, it is clearly stated that everything should be designed, should be clear in the beginning itself. What we are going to teach, how we are going to teach, and how we are going to assess. It should not be that after finishing the course, we are thinking what to ask, what to do. That should not be the thing. And this is the new thing that has been introduced, and all of us have been trained in that by our medical education units. So we know that formative, summative, and everything in our module, we have tried to include what can be done in formative, what can be done in the summative assessment, what are the different forms that can be taken, like in clinical and community postings, ward livings, we can use that for formative evaluation and feedback. We all know that, but how that is to be done, in which session, what can be asked, that is given in the module that we have designed. Like in summative, what are the portions that can be taken for theory, for small structured questions, then what can be asked in MCQs, all those things. We have also tried to give sample questions and sample MCQs that can be included, and like it is for the department to basically decide. They can make modifications, and but this is just a sample, a model that has been given, which can be improved upon. And then allocation of marks prefixed, how many will be covered in theory, what will be there in practical, that is also in a way we have suggested, which can be adopted. Then in theory, like we can have, we know that now it has been made mandatory that there should be multiple choice questions in all the subject. Up to 20% multiple choice questions can be given for assessment. So what are the questions that can be asked in MCQs, short answers, structured essay questions? So we have tried to provide all the types of questions that can be included in it. Then for assessment, OSCE is being promoted, and even in OBG guide pediatrics, they have basically started assessing students on this. So how we have also given some model OSCEs which can be included, and now it is up to the different departments of how they can improve upon it. Antenatal cases with special emphasis on maternal nutrition, these are the various topics we all know, we all have been covering. So these things have been included. Basically, I just want to show what all is there in the module that has been prepared. Everything has been covered, like in antenatal case, in postnatal case, what are the various things that are there and how it can be done. Then for practical assessment of cases in the community, assessing factors affecting MIYCN, like students can be asked, we can have a small survey when we are taking them to community, like go and conduct survey in 15 families, 20 families, and then we can have a discussion with students. So basically with teaching, we can have this in practical. When we are doing assessment, we can either refer to what we did while teaching, we can ask them those questions related to that, how they basically assessed and what were their, because this will improve their attitude towards the whole thing. Then neonatal cases, because it's not only community medicine that it is there. What was done was we had faculty from community medicine, pediatrics, and OBG. We all sat together, and this was done by 8 to 9 medical colleges that participated in it. And it was initially done at the college level, where all the 3 faculty, all the departments, the 3 departments sat together, they had discussion, and then they came to the minimum thing that can be included along aligned to CBMA. And then the whole thing was prepared. So in our module, we have inputs from OBG and pediatrics, and they have helped us in preparing. Of course, we wanted community medicine to be the team leader and take, because most of the time they are involved in clinical work, so they don't have that much time to share. So they basically came forward and helped us in preparing these modules, and the OBG and pediatrics part has also been taken care of nicely. So these were the case-based scenarios that were basically given short cases. We have given model short cases that can be given for demonstrator of skills. What are the topics that can be covered? Preparation of diet plan. What are the different age groups that can be included for role play? Like everything. And this should be there not only in the teaching part, this should be there in the assessment part too. So that because we know that whatever is not assessed is not learned. So this should be there as a part of assessment too. So role play we can have in OSCE, we can have on station for role play. Sorry, not role play, for demonstration, for skill demonstration. They can say that now you can demonstrate how this counseling is to be done. So they can show it with the help of their colleagues, with the help of their friends, They can show us that. Now, the question that comes is feasibility of implementation. In the current scenario, will it be feasible, and who would be responsible for doing this? Now, we all know that in curricular implementation support program, if we look at the curricular governance, we have topic teams. Topic teams have been assigned, and these topic teams have been given the responsibility. When we looked at, like when we were preparing this module, we just wanted to know whether we are aligned with the CBME or not. So we saw that in curriculum implementation support program, these aligned and integrated topics were suggested. And there this nutrition was there. And from nutrition, we made the application part of it, we took out, and then we prepared a curriculum of maternal, infant, and young child nutrition. So this is very much aligned to the curriculum that has been given to us for implementation in medical colleges. Now, we all know that this was the responsibility given to the topic team. So the topic team of MIYCN in each medical college, for them, we have this capsule available. They can take help because we have to find out topics which can be basically taught to students in an integrated way. So MIYCN का जो topic है that we have already prepared, we have this capsule ready, we have put everything, all the 3 subjects together along with medicine, general medicine and biochemistry, some aspect of it. So this topic team was, we know for CISP, they were responsible for creating learning and assessment sessions of these topics. Then they should have adequate representation for subjects involved. So I can see and I can tell you that we have all these things done in the curriculum that we have developed. The competencies and hour assigned. So it is completely aligned with CBME. It is basically something which can be used as a ready reckoner by all the medical colleges and can be implemented. And this will be a great thing and a good step forward from the Department of Community Medicine. Thank you. Thank you for providing me this opportunity.
Thank you, Dr. Rama Pathak, for providing such a module, which is the need of the hour. The module looks perfect, fitting into the national needs, as well as presently, if you pick up the definition of CBME, it says the new thing which is added is community involvement. So you have involved that, so that goes into that. I was just looking at the way you have done it in the perfect way. You have taken care of the guidelines, the topic teams, how they will work. You have already planned out how it will implement. That is a very wonderful way, actually. This looks like a model curriculum for integration. As you know, 20% curriculum has to be covered. You have picked up one of that from the document, list of the document. So I think as already you are planning to share it as open access, so that will be something other people actually can use it. Because a lot of the institution, as you know, started integrated topics, 3 or 4 they have chosen to cover 20% target, and they will continue with that. But we have a lot of new colleges who are starting this year. So they will be looking out for not new topics. So I think this perfectly fits into that, and other colleges establish also if they are planning to change their integrated curriculum. This is the whole story of development. You should also publish a story of development and how you have picked up and make a module of 38 sessions and 42 sessions in theory and practical, and integration of 14, 6, and 4 competencies, department-wise, which you have done. And you have shown that the planning takes a lot of time in integration.
Yes, sir. It took us 2 years, sir. Basically, before we could actually come up with this, we had, and it was integration, like we had discussions with so many medical colleges because we wanted to convince us we should be on one platform to be able to actually deliver it.
In fact, that is the message I wanted to take out from here, that integration means integration of the concept, which you have done right now. Now it's the delivery, which the people has to do. And there was one question related to that. Somebody has asked that number of faculty, the challenges will be the number of faculty. Would you like to respond to that?
So number of faculty, that is something which is basically whatever number of faculty which are available with us, we have to actually work with that, because most of the time it happens that even though we have good number of faculty in the department. Most of them are not that active or they don't come forward to participate. We can't push them. So the number of faculty is definitely one of the requirement because if we want small group teaching, and the way small group teaching has been, it has been asked to take maximum number of classes in the form of small group teaching.
Let me add to that also what you are adding already. A lot of people, when we say integration, they assume lot of teachers will come and take a session. But the lot of teachers actually need to be involved in planning, not in taking sessions. You have already made modules, okay? Lecture, what competencies are covered. In the psychomotor and affective domain, you have already listed these competencies to be covered. Even one teacher can take that. If other subject competency, a small part you are taking, and other teacher is comfortable, they can take. So it's the integration of the topic and not the integration of the teachers, basically. So that challenge should not be seen from that point of view that you need to put 5 teachers in 1 hour. But you need to put all the teachers from the involved subjects for the planning of the session. And you 5 will decide. Yeah, you 5 can decide how the session will be taken. Oh, yeah.
But we need to have adequate number of teachers.
Yes, yes. That you need.
We can't do with shortage of staff. That will faculty, the number is less, then the quality will not be that good.
No, it's just for the concept of integration. People assume if you don't put 5 teachers in 1 hour, it is not integration. So the concept which has been given in the curriculum is integrate the concept, delivery, then you decide how it's to be done. You have ample number of faculty, use them. You have a limited number, you use them optimally in that way. There's another question which has been asked that is there a scope for reflection writing in the process?
In the reflection writing in community setting, so whenever we are taking, it's very important, whenever we are taking them for field visit, we have to ask them to come back and do the reflection writing. Whatever was taught, what was their perception, because reflection writing is mainly to understand what is their attitude and what is their perception. So we need to basically, in community medicine, we have, and that's how we have aligned and we have given the topics where they can do the reflection writing, and especially the topics which are related to national policies. So what is their opinion, what is their understanding, we have to know. So reflection writing, community medicine, we have many options, we have many opportunities.
Yeah, yeah. So a lot of people are asking about availability. I think it has been already shared. The link has been shared by the organizers for the module, so they can take it from there. And a lot of people have appreciated the module, which is there on the comments. So they're really looking for that. And some of them are asking, can we start from the second professional year? We just talked about that they can start. New colleges or the established, both can start from that. Availability is there, so no need to reinvent the wheel again and again. Actually, most of us actually need to. If you allow us, we can share your link with the nodal and regional centers. As you know, they are all connected to MEU. So instantly, it will be in all the medical colleges in 1 or 2 days.
That will be really a great help, sir. This is what we have been actually looking forward. Because and they can modify, and we would be very happy to see if they can have more recommendations, suggestions. They can. We would be very happy to incorporate all that.
Next year, maybe you can come out with the second edition.
Yes, that's.
Thank you so much, and we appreciate. And Dr. Sareka, you want to add?
Thank you, thank you. No, absolutely, you have summarized the whole thing very nicely. And Dr. Ramba, we would like to congratulate both the chairpersons. We would like to congratulate you for a very excellent presentation and the work you have done. And I think we need to replicate your, presentation, and we need to make other people aware of and give their valuable inputs. Yes, yes. Definitely wonderful, wonderful, wonderful.
Thank you, ma'am. Thank you.
Even the people can take example how you develop this. They can even choose another topic. Your process is actually very, very good, which you have used.
Thank you, sir.
Yeah.
Thank you, ma'am. Thanks a lot. Thank you very much. Thank you, sir.
Thank you, ma'am. Thank you. Back to Dr. Sailesh.
Okay, thank you. Thank you, Dr. Pathak. Dr. Ramba and our esteemed chairperson, Dr. Surekha Kishore and Dr. Dinesh Badial. Really, this was an excellent presentation and good understanding. I think every participant may have a good understanding of how curriculum integration can be done in one department. So thank you for your contribution to this session. So now I would now move to the next session, which is on maternal nutrition topic. So for this session, I would like to invite our chairpersons. First, I would like to invite Professor Dr. Vikas Bhatia sir. He is a director AIMS Bibi Nagar, Hyderabad, and he had been the founder dean and had started 58 academic courses in newly started AIMS Bhubaneswar. And he was the first among the first to start the advanced resource center in public health nutrition and fellowship in public health nutrition. He has been the editor-in-chief of Indian Journal of Community Medicine, Community and Family Medicine. Apart from working with medical colleges, he had an vast experience of working with development sectors, partners, UNICEF and WHO and other different agencies working on health and nutrition component. And to his credit, he had completed almost more than 50 projects across different themes, and he had almost more than 140 publications, published articles around modules and books to his name. He had been the chairperson for the 7th Central Pay Commission for Autonomous Institute and is the chief vigilance officer for the AIMS Bhubaneswar. And he has been honored with numerous awards such as an appreciation in innovation for exceptional performance during Poshancon 2018 by WCD Niti Aayog, and various awards. He has been the recipient of various awards. Okay. So welcome you, Dr. Vikas Bhatia sir, to chair this session. And the second chairperson for this session is Dr. Rakesh Kakkar. He is the professor and head community and family medicine and MS AIMS Mangalagiri. He has received a presidential appreciation award in faculty category at IAPSM conference. He is an IAPSM fellowship announced in 2019 IAPSM conference. And he is the editor of IAPSM's textbook of community medicine. Also the editor of Indian Journal of Community Health in 2016 to 20. And importantly, he is also the chairman of the RNTCP State Task Force in Uttarakhand. So welcome you, Dr. Rakesh Kakkar. And I would request the chairpersons to invite the speaker for this session. Thank you.
Thank you, Dr. Shailesh. And thank you, Dr. Amir Maroof. It's a privilege for me to chair this session. I would like to thank the association, Kadri sir and Sanjay Jodpe sir, and all MIYCN group. I can see a lot of dignitaries connected online. So I welcome all the dignitaries. And now I would like to invite the speaker for this session, and that is Dr. Ravneet Kaur. Dr. Ravneet Kaur is an associate professor at Center of Community Medicine, AIMS New Delhi, and is trained in skill training and development of e-learning program. So this will be helpful to all of us. And she is well experienced in maternal nutrition. So as a member of working group of Ministry of Health and Family Welfare for preparing operational and technical guidelines for antenatal care, maternal nutrition, management of high-risk pregnancy. So hopefully this session will be very good for all of us. She has a lot of experience in anemia. She's a member of National Center of Excellence and Advanced Research on Anemia Control, and has done research on various aspects of maternal anemia, particularly operational guidelines for program manager on Anemia Mukt Bharat, and prepared an e-learning module also for Anemia Mukt Bharat. She is active member of MIYCN IAPSM working group and also managing editor of MIYCN Bulletin, and has many research publication to her credit. So I welcome Dr. Ravneet Kaur.
Thank you, sir. And thank you. Very good afternoon to all the chairpersons, the panelists, and esteemed participants of this course. So the topic that I would be discussing today is maternal. I'll share my slides here. So I hope my screen is visible. I'll lead it into the...
Yeah, it's visible.
Yeah. So the talk which I'm going to take today is maternal nutrition, critical but often missed. And though I'll be sharing some of my experiences in the research that we did as a member of the expert group, but I'll also be doing largely a situation analysis and the way forward that we are going to do in India for maternal nutrition. So we all agree maternal nutrition is critical. Indeed it is. It manifests in various forms and affects both mother and fetus or the newborn, be it anemia or general protein energy deficiency. It leads to low birth weight, preterm birth, and it leads to maternal mortality. Not only that, babies who are born preterm and low birth weight, as we all know, they lag in growth and development and may also land up in poor neurocognitive development. So as we look at the micronutrient deficiency, deficiency of folate results in neural tube defects. Calcium deficiency may increase the risk for preeclampsia or eclampsia. And gestational diabetes, now, though it was earlier thought of as a problem of the elite and urban groups, it is no longer a problem. Overweight is now seen across all groups, albeit rural, urban, rich or poor. So GDM leads to macrosomia in the baby, and it leads to increased malnutrition. Overall increases the risks of infections for mother and lead to maternal mortality. So we cannot ignore the fact that maternal nutrition is very, very critical. Now, how much is the burden of the maternal nutrition in India? As I said earlier, it manifests in various forms. So anemia by far remains the most common form of maternal malnutrition, with 53% of pregnant women all over in India. This is the NFHS4 data, which suffer from anemia. Now, this is the national average, and you may agree that it varies from various districts to various states. And in our secondary care hospital at Ballabgarh, which is the field practice area of the Service Delivery Point Secondary Level Institute for AIMS, we found that 78% of the women who came for delivery were anemic at the time of delivery. And out of them, more than 1/3 were moderately anemic and more than 8% were severely anemic. So even after decades and decades of work in anemia, we have not been able to conquer this problem. The next common form of malnutrition that we see is underweight. So 23% of pregnant women enter the pregnancy in an underweight stage. Earlier mentioned, 21% of the women are either overweight or obese, which, as we know, leads to the complications in the baby. Too short is another nutritional complication, and 11% of the mothers actually in India, they are of short stature. To complicate the matters, you see nearly 8% of the pregnancies are teenage pregnancies or underage pregnancies. So to summarize, the problem of maternal malnutrition in India is in terms of women who enter the pregnancy as too short, too thin, too young, have anemia or are overweight. And besides this, we have other micronutrient deficiencies like iodine deficiency or fluorosis. And to worsen the matters, we generally have a combination of this: undernutrition with anemia, undernutrition with teenage pregnancy. So this is the magnitude of anemia. I'm not going into the detailed stats because that were discussed yesterday by the speaker from the ministry, Dr. Ghosh. So I'm just giving an overview in this presentation. So as you can see, we have a huge burden of maternal malnutrition in India. Though this slide, I have labeled it as intergenerational life cycle of anemia, it holds true for other forms of malnutrition as well. We have an intergenerational life cycle of malnutrition. It travels from one generation to another, from women to adolescents and pregnancy, infants and young children. And then the entire generation we have is of malnourished children, and the cycle continues and continues. However, despite this burden, we have been able to reduce maternal mortality to a great extent, primarily because of skilled attendants at birth and programs like Janni Suraksha Yojana. However, maternal malnutrition and its consequences have largely been restricted only to maternal nutrition assessment, which in itself is limited to gestational weight gain monitoring and hemoglobin estimation. And as far as you would agree, nutritional interventions are concerned, it is only to conquer anemia in terms of IFA tablets. And we all know how much is the consumption and compliance to the IFA tablets. Though now with the Anemia Mukt Bharat, parenteral iron has been introduced, but yes, it is in progress. The other nutritional intervention is supplementary nutrition under the ICDS, and the previous speakers have already enlightened us how the status is. So in a nutshell, I would like to emphasize that though it is a very important aspect, but maternal nutrition has not gained as much importance as it deserved in the antenatal care till now. So in 2016, the World Health Organization launched the antenatal care guidelines, which placed substantial emphasis on nutritional assessment of pregnant mothers and provision of a set of nutritional interventions. So the emphasis, I would be highlighting these points: nutritional interventions and maternal and fetal assessments. So maternal and fetal assessments, there are a number of other assessments, but I have limited myself to those which are relevant to India, as many recommendations of those 2016 guidelines, most of you would already be knowing, are context specific. They have to be modified to a particular country or a context or a community. So I have listed here the anemia, which the WHO has said. In the later slides, I will just discuss what has been proposed in the guidelines for the ministry, which are under preparations. So anemia and the WHO guidelines, they indicate that we should use low-cost, reliable methods, point-of-care testing. For example, paper chromatography in low-resource settings, and wherever possible, point-of-care testing by hemoglobinometers. Asymptomatic bacteriuria. Now, these WHO guidelines, they have identified nutritional risk and medical risk. So though asymptomatic bacteriuria is a medical risk, it has been, I have included it here because it is a major reason for preterm and low birth weight. So they also recommend that we should do an assessment for asymptomatic bacteriuria, even in resource constrained settings, by the dipstick methods. Then gestational diabetes mellitus, OGTT they have recommended. Undernutrition with a variety of anthropometry, height, weight. As in India, we said only gestational weight gain, monitoring of gestational weight gain is the only thing that is being done, and other micronutrient deficiencies. So I'll come back again to these assessments in terms of the Indian context, but what is important here is the purpose of all this assessment is to identify women who are at nutritional risk and then providing them with customized counseling and other nutrition interventions. Now, what are the evidence-based maternal nutrition interventions? Now, as I mentioned earlier also, there are many more, but I have restricted myself to those that are context specific with respect to India. So some important evidence-based maternal nutrition interventions include iron folate, that is IFA supplementation, for prophylaxis, prevention and treatment of anemia, provision of supplementation of energy and protein, calcium supplementation, 500 milligram, deworming, counseling on nutrition. We have been listening these terms since morning, and prevention and treatment of maternal infections. Now, in India, what is the proposed screening? And it's already been identified that we have to do certain assessments and then identify at nutrition risk, and what are the cutoffs or what are the criteria for this screening on and identification of at nutritional risk mothers. So as far as height is concerned, as we have seen, short stature, we all know is a risk factor. So stature less than 145 centimeters, then measurement of weight. So BMI before pregnancy or before 20 weeks of gestation, less than 18.5 kg per meter square would classify as underweight. But as we know in India, the registration during early pregnancy before 20 weeks is very less. So how do we identify underweight women there? So mid-upper arm circumference has been suggested to indicate underweight, and undernutrition, and a cutoff of less than 21 centimeters based on literature review. Various studies have been published. So mid-upper arm circumference will give us an idea of undernutrition in women who are beyond 20 weeks of gestation. And then monitoring of weight gain. Gestational weight gain monitoring. So if weight gain is less than 1 kg per month, it would be identified as that this is a pregnancy which is at nutrition risk. Then hemoglobin, so identification of anemia, and it is graded as mild, moderate, and severe as per the guidelines, mild being 9 to 11, moderate 7 to 9, and then anemia less than 7 being severe. And also visible fluorosis and goiter. Now, this was discussed in length as to include these micronutrient deficiencies, as many field workers at VHNDs may not be able to palpate goiter, but then it was decided that yes, if it is a visible goiter, of course, it should be indicated, because iodine deficiency during pregnancy, it's a public health problem in India, and during pregnancy, it has far-reaching consequences in terms of cretinism and mental retardation. So this is the screening that is required for identifying at nutritional risk mothers. Now we come to the maternal nutrition interventions in India, and I would first like to take up anemia because of two reasons. One, because it is the most common problem, 53% all over India, and secondly, because I've been involved in the guidelines that were prepared. So in 2018, the Intensified National Iron Plus Initiative Program was launched, which is also known as Anemia Mukt Bharat. It is a very ambitious program with a 6x6x6 strategy. And though it covers all the age groups, I'm focusing on the topic of today, that is maternal nutrition. So as recommended in the WHO guidelines, the AMB also recommends testing of anemia using digital methods and point of care treatment. So the strategy, as we say, is test and treat rather than as in other tests, like you take a sample and then the woman comes again and then we have lost to follow up. But here you do point of care testing and you treat that and then. So why point of care test devices? It has many advantages. A small volume of blood sample is required. We do not need expert persons. There is ease of obtaining the sample. It can be easily used in community settings, rapid turnover time. You can actually test a large number of beneficiaries as in VHND or in other Anganwadi centers. You can use it over a large number of beneficiaries and there is no loss to follow up. It is amenable to actually test and treat there and then. So we have faster access to test results, rapid clinical decision making, and rapid treatment and interventions. Now, for point of care, regarding point of care tests for hemoglobin estimations, a number of methods are available as I have listed, but the Anemia Mukt Bharat indicates invasive digital hemoglobinometers like HemoQ, which may be, there are various models, so depending on state to state. So digital hemoglobinometers, I have shown two models, these can be used. And see, the ministry has already come up with the specifications for these digital hemoglobinometers, and the states are procuring them under their PIPs. So this is already, the program is running for using these invasive digital hemoglobinometers for estimation of HB. A lot of studies have done which have validated the use of these digital hemoglobinometers. One of the study was done at NCRA also, and it has shown that it has a very good sensitivity and specificity, sensitivity to the tune of 93 to 97% and specificity of 76% as compared to the gold standard, which is the direct sign methemoglobinometer. So it has been recommended for use under the Anemia Mukt Bharat. It is very easy to use. We have developed an e-learning module, a video module, which Dr. Bhatia sir is not here, but he is also an active member in the AMB, and it has been used across the country for training of master trainers for how to take measure hemoglobin in the field using these point of care devices. So this is what has been recommended. And then we come on to supplementation and prophylaxis. And by now, I think this is a learned group. All of us are aware that there has been change in the dose of elemental iron. Now, the prophylactic dose is 60 milligram of elemental iron with 500 microgram of folic acid. And from enteric coated, it is now sugar coated. from 4th month of pregnancy. So now instead of 100 tablets, it is recommended to give 180 tablets, and it can be given in ANC clinics, VHNDs, and PMSMA. So also all women of reproductive age group, currently what is focused is 19 to 24, not other up till the entire age group. So preconceptional period, actually, they are being given folic acid. It is a recommendation to give them folic acid to reduce the neural tube defects. Also, is the recommendation to give 1 dose of albendazole, preferably in the 2nd trimester of pregnancy for anemia, and in malaria endemic areas, distribution of insecticide-treated bed nets and other interventions. So this is the therapeutic management of anemia. I'm sure, because I have to stick to time, I'm sure most of the people are already aware, but that this is based on the level of hemoglobin and the gestational age. But what I would like to highlight here is that now under the Anemia Mukt Bharat, parenteral iron has been introduced. So why parenteral iron has been introduced? Because we all know the compliance to oral iron has been very low even after decades of implementation of the iron folic acid supplementation. So iron sucrose injection, the details can be discussed at some, we have some publications they can be referred to. It is now also in the state PIPs, and the states are procuring iron sucrose. And ferric carboxymaltose, though it is not recommended for use, and as of now it is not there in the guidelines to be used for and during pregnancy, because we are awaiting some approvals. But yes, IVIS has been recommended for use in pregnant women. It offers various advantages. We have done some studies, and we found that mean increase is much higher in a much shorter duration of time with because it is based on the calculation, which is based on deficit of HB. So the severe, even the women who have more deficiency of HB respond very quickly, and a much larger increase in HB is seen. And we have seen that with ferric carboxymaltose, we could find, we did the study in postpartum women, we did in antepartum women also, but the recommendation is yet not there in the national program. So for antenatal women, so we found a considerable increase within 4 to 6 weeks of time. Now, what are the advantages that parenteral iron offers? There are no issues with the compliance. There are no GI effects because oral iron has to be known to be associated with considerable GI effects. And that is the reason the dose has been decreased from 100 milligram of elemental iron to 60 milligram of elemental iron. It leads to a relatively rapid rise in HB. And though IVIS requires at least 4 visits, but in case of ferric carboxymaltose, there is a single visit, usually 1 or 2 visits, single visit, dose is calculated based on the formula. And thus it has immense value both to the patient as well as the health system, though there are no guidelines for use in pregnant women. But yes, in postpartum women, we have definitely an advantage because there is a guideline for discharging them after 48 hours. And we can use this opportunity to measure HB in women who are with us during the hospital. And then before discharge, according to the category of anemia, we treat them. Because it will be again a great service, because women in India, they tend to enter the second pregnancy with the delivery. They think that the target is now achieved, and they are continuing without, though we have a recommendation of giving postpartum iron up to 180 days also, but the compliance, again, if it is so low in ANC, we can well imagine how much would be the compliance in the postpartum period. So for such women, before discharge, if we give them FCM or other forms of iron, or we correct the anemia, just to say that, we can prevent them entering from the second pregnancy with anemia. And it as such also is important because lactation, anemia has been shown to hamper lactation, has been shown to hamper the maternal-infant bond, and also this leads to poor neurocognitive development in the infant also. So thus correction of anemia in postpartum women also prepares them for the next pregnancy. So that is why I've included it in maternal nutrition here. So this is in brief about parenteral iron and its certain advantages. And other nutrition interventions that we have discussed even in the morning presentations, these speakers have assessed those: improved dietary intake through nutrition education and counseling, provide nutrition and lifestyle education, test and treat underlying diseases as asymptomatic bacteriuria, GDM, fluorosis, goiter are just the examples. Monitoring of blood pressure and blood glucose levels monthly, and indicators of UTI, and monitor gestational weight gain. So these are the other important interventions that have been suggested. But now these are the suggestions and recommendations, but in India, we face considerable challenges. So ensuring early and regular contacts for ANC, only 21% of antenatal women received full ANC and 16% do not receive any ANC. So the guidelines are now being modified to include more contacts. So not only visits, but more, at least 8 contacts, so that at least a healthcare worker contacts the women and provides them with education, counseling, and at least makes them to visit the ANC and do all these testing and nutritional assessments. So undertaking maternal nutrition assessment, ANC currently includes only weight gain monitoring. And as we could see that in the morning presentations, this also has considerable gaps in terms of coverage, availability of weighing scale, and all such conditions. Now, currently, we do not have any customized counseling because we are not identifying women who are at nutritional risk. So this is a challenge that we have to overcome. And consumption of IFA tablets. So we saw in the morning presentation that there are gaps in the demand supply, though this is also being work is also being done in the ministry to handle this demand supply chain. So at least for 100 days, and we see that the compliance is much less, 9.7% in Bihar and 13.4% in Tripura, 17% in Rajasthan. So very, very less consumption of IFA. And parenteral iron can help us in this, in such situations. So these are the challenges that we face in India, but how to overcome these challenges? We have a few opportunities here. So we already have the available platforms such as PMSA and VHND, and a number of nutrition interventions are already being done through these kinds of platforms. So we can further use these platforms. We already have these platforms, and these can be used. As we can see in Godbharai, we have this red IFA tablet here. So these can be used. PMSAs, VHNDs, national, even rural livelihood missions can also be roped in. Then universal inclusion of maternal nutrition screening. So this is a lot of work that we need to do, but it's simple measurements, simple screening and counseling. So it is suggested that we will begin with the PMSMA, and then it will be rolled out, and targeted nutrition package for at nutritional risk women in linkage with ICDS and NRLM in aspirational district. In fact, a lot of work has been done. There is, as we have a National Center for Anemia, so in ministry, a lot of work has already been done in identifying at nutritional risk. So at nutritional risk, but no medical risk, at nutritional risk as well as medical risk, and then targeted packages for each group. So these are a few ways by which we can, overcome the challenges that we have in terms of maternal nutrition. In a nutshell, I would like to say that the problem of maternal nutrition is very important. The magnitude is high. We have a lot of work to do, but yes, we have challenges and there are opportunities also. Now, this is the counseling material that has been prepared already. These are some IEC material that has been prepared for mothers, for pregnant women, involvement of husband, diet diversity, and all these material is already in preparation. So this is my talk, and yes, I agree with Mr. Ratan Tata here that it is important to do something for pregnant mothers because this affects our next populations. Thank you very much.
So, thank you, Dr. Ravneet, for a comprehensive presentation. You have covered all the problems and challenges you are facing, or anyone, in fact, anyone is facing, and you have also suggested some solution that how to tackle these challenges. Though anemia is very common thing, as you have told that it is around 53%, but in some of the state it is even more than that.
Yes.
So everyone is aware of this problem, but still we are facing this problem from many years. Many strategies, many policies have been changed, but still a lot has to be done. Still, translational research is required in this area also. And we can utilize the grassroots level workers and these new sub-centers. And what is actually their problem, we have to come at that level to find the solution, effective solution for them. So, thank you, Dr. Ravneet. It was a nice presentation.
Thank you, sir. Thank you very much.
Over to Dr. Shailesh.
Okay, so thank you, Dr. Rakesh Kakkar sir and Dr. Ravneet for your presentation on maternal nutrition and focusing on anemia to address the issue of anemia among pregnant women. Thank you very much. So now we'll be moving to our next session. And with this, so I would now hand over this scientific technical session to my friend, Dr. Amir Maruf Khan, so who will be taking forward the further sessions. So I would like to introduce him, Dr. Amir. He is an associate professor of community medicine from UCMS GTV Hospital, Delhi. As you all know, he's an honorary secretary with this MIYCN-IAPSM National Working Group. He is the editor with IAPSM's textbook of community medicine, associate editor with the textbook of community medicine, and associate editor time research and humanity in medical education. And he is the honorary secretary of Consortium Against Rabies and is the president for Teachers Association, UCMS Delhi. So I welcome Amir to take the session forward. Thank you.
Thank you, Dr. Shailesh. Now we will move on to the next presentation. There are three sessions in fact remaining. One is a private health sector session, another is the panel discussion, and then the paper presentation session. So this presentation, MIYCN and private health sector, this topic of this session, thus how it has been done by MIYCN and in partnership with the IAP and FOXY. So it's great to see the chairpersons from IAP and FOXY here. So I would like to invite the chairpersons. First of all, Dr. Vidya Thobi. She is the professor and head Department of OBG at Al Amin Medical College, Vijaypur, and chairperson Food and Drug Medico-Surgical Equipment Committee, FOXY 2018-20. And she has been a governing council member. She's a governing council member for ICOG and also editor in reputed journals. And she has organized various programs and she has that the various academic council members and positions where she is well versed with the teaching aspect also, the administrative aspect also, and managing the organizational aspect also. So I think this is a complete package, you can say, where ma'am is taking all the things, these things simultaneously, and then only we can make an impact. And we thank her to be here with us with this program of MIYCN-IAPSM. Thank you, ma'am. Next, I would like to invite Dr. Chentil Aram. He is the President, Indian Academy of Pediatrics, Tamil Nadu State Chapter, a Senior Pediatric and Adolescent Health Consultant, associated with Hospital Urgamethi, Hospital Neveli. And he has received the Active Pediatrician Award, and he has conducted many community-based adolescent awareness programs. So it's great to have from IAP and also from Fox. So we welcome you, Dr. Chentil, as the chairperson for this session. Over to the chairpersons now to conduct the further proceedings.
Yeah. Thank you very much for the kind introduction, and it is always a pleasure to be associated with all the talented and academicians here and who have given so much. From yesterday also the sessions were quite good, and today morning also I enjoyed right from the quality assessment and the integrated curriculum, and now we are and also the maternal nutrition. Now we are really how to know about the what does this maternal nutrition, what are the how to decide that what is the position and what things are happening in various population of India. So I just want to have some comments that whenever we include this in curriculum, and especially in the community medicine of various medical colleges, it will definitely have impact, because the large government medical colleges where these women and they are screened for the high risk pregnancies, or when we tell them about the nutritional risk assessment, definitely we'll get some data that how much our women are nutritionally deficient. So I just want to I want to thank, in fact, the Alive and Thrive group, Dr. Shailesh Jagtap, and the organizers of this conference, Dr. Khan, and others. This is the first of its kind, that this is the first national conference of MIYCN and IAPSM. And really, it will be an eye-opener for the whatever things, stakeholders and everyone in the whole of India, what I feel. And I would like to be a part in future also of whatever things are coming up, like we want to have some e-learning module and all. Leaving apart, I just want to invite our esteemed speaker on this session, who will be talking about the MIYCN and the private health sector, the preliminary survey report, which will be the integral part. And may I have his CV? Dr. Lalit Sankhe. So he is associate professor of Department of Community Medicine, Grant Medical College, and Sir JJ Group of Hospital, Mumbai, fellow Indian Public Health Association, secretary IAPSM Mumbai branch, executive committee member of MHIAPSM, editorial board member, Indian Journal of Public Health, Frontiers in Public Health, and he has also worked as a nodal officer at the Regional Geriatric Center National Program for Healthcare for the Elderly in Government of India, and at the various positions in Maharashtra, in Department of Health Research and Government of India. And adult vaccination, he has also worked in the Adult Vaccination Center, recognized by WHO and Government of India, associated also as well. So I just want to have from his learned voice that what type of surveys we can further include in ours also. We can take lessons from him. Let us know, Dr. Lalit Sankhe, from your expertise, how we can also go ahead with the various surveys. Thank you very much, and over to Dr. Sankhe.
Thank you, Madam Vidya, for a nice nice and good words for me. And I take this opportunity. Amir, can I share my screen?
Yes, sir.
Yes, I think.
Yes, sir, you can do.
Yeah. Now it's visible, I suppose.
Yeah, but you have to make it slide share.
Yes, I will. So thank you very much, Madam Vidya, for nice words. And before I start, I would like to just bring us back to yesterday's presentation by Dr. Pandav, that he mentioned important aids during his presentation, which are very important for and infant child nutrition program. First A stands for I, that is Marathi word for mother or ma. And I take this opportunity to wish you all, everyone, a very happy Navratri or Ma Durga festival, which is starting from today. Secondly, I'm very happy for the organizers, specifically the president, Dr. Sanjay Jodpe, then Dr. Sunina Garg, then Dr. Kadri, who is Secretary General, and Dr. Amir, who is organizing this event. They have aptly timed this event by starting the event by yesterday, that was World Food Day, and then they are concluding today this particular event by the blessings of Ma Durga, which will help us to combat over the maternal and infant child nutrition. Okay, my today's presentation is about MIYCN and a private health sector, a preliminary survey report, which we did a study of a rapid assessment of knowledge and practice regarding maternal, infant, and young child nutrition amongst the obstetricians and pediatricians working in a private health care establishment. Basically, this is a unique model where we try to converge and do the partnership with Indian Association of Pediatrics, the Federation of Obstetrics and Gynecological Society of India, and we had the development partners, Bill and Melinda Gates Foundation through FHI 360, through Alive and Thrive in India. And the major study partners or the major stakeholders was IAPSM, who were coordinating with IAP, FOXY, and the development partners. The study investigators, myself, Dr. Lalit Sankhe, and my colleague, Dr. Chaya Rajguru from Grand Medical College, and a project lead from FHI 360 were Dr. Shailaj Jagtap and Dr. Vishal Sastry at Alive and Thrive. So this is the model where we are going to work with different associations on the various modes, how to conduct the research, and then how to collaborate with each other. That was a major focus, and we are successful in that of establishing a good model where we as IAPSM can work very well along with IAP and FOXY, and that is a good thing which has come out of the major thing which has come out of this particular study. So we are open. Madam, IAPSM is always open to work in partnership with IAP and FOXY at all levels, along with the development partners which will be there. Background of this study is all well. Everyone has been talking about maternal and infant child nutrition for last 2 days. And I would just like to tell you, nutrition is essential for the success of all SDGs, which is not, I think, which are not touched by anyone, but I specifically tell everyone that the nutrition is essential for success of all the SDGs. The nutritional status of women and children is particularly important. This has been covered, and this has been spoken by almost everyone during last 2 days, then 2 days in this meeting. Inadequate maternal nutrition and inappropriate infant and child feeding practices continues to contribute the major global burden of disease like malnutrition. In 1/5 of the under 5 child mortality can be prevented through a single intervention of exclusive breastfeeding, and government is committed at national level through Poshancon for prevention of malnutrition and promoting MIYCN at country level. So the rationale for this study was the India's progress in IMNCY has been below desired level and uneven with wide interstate disparity. This is a well-known fact for us. And out of 26 million hospital births which takes place in India, almost 40%, that is 12 million newborn, are breastfed within the first 1 hour of life, which is what we want. Is almost 100% should be there, but only 40% is breastfed, so newborn. So we need to focus on that. And then the professional medical associations definitely have an influential role in improving these practices by integrating maternal nutrition intervention in various places where we promote maternal and infant nutrition. Maybe at ANC, promoting, protecting and supporting optimal breastfeedings and creating mother and baby friendly environment at the hospital level. So we thought of having a rapid review of current knowledge and MIYCN related clinical practices amongst private practitioners who are members of IAP and FOXI to enhance understanding of care provided by private sector related to MIYCN for planning future interventions for improvement. Study goals and objectives. Basically, we had the goals to assess the current knowledge and practices pertaining to MIYCN and to understand the key bottlenecks and barriers to identify the opportunity in adopting the evidence-based MIYCN guidelines. Objectives, I will go hurriedly to assess current knowledge, to understand the current practice and willingness to adopt, to understand the systems and processes which are there, and we can strengthen it through the evidence, and to identify the bottlenecks and challenges. Primary outcomes of this study were to identify gaps in knowledge and practices of the services provided in a private sector, identify gap in the system and the process in places for inclusion into the MIYCN intervention, and identify facility types which can be suitable for adoption of MIYCN services in private healthcare establishment. Research methods, a mixed method cross-sectional observational study was designed with both qualitative and quantitative component. The data collection methods were online surveys and on-site facility assessment by in-depth interviewing and observing the facility. Tools which were developed were for online survey. We had an Kobo toolbox where we had developed the interview schedule, and then the semi-structured interview schedules were developed for obstetricians as well as pediatricians, and there was a facility observation checklist which was prepared. Online surveys was a nationwide survey for all obstetricians and pediatricians who were part of FOXI and IAP as their association. Online facility assessment was conducted in 5 states. These 5 states were selected basically on their representation of 50% of the population of the country as per 2011 census, with maximum number of undernutrition and sufficient numbers of practitioners which are present in this particular state. The states were Uttar Pradesh from North Zone, Bihar, East Zone, Maharashtra, Gujarat, and Karnataka. A diagrammatic representation of the study is a quantitative, which was online nationwide survey. Qualitative, we did in Uttar Pradesh, Bihar, and then there were in Uttar Pradesh, we had Lucknow, Varanasi, and Aligarh cities. In Bihar, we had Patna, Darbhanga, and Gaya. In Maharashtra, we had Mumbai, Nagpur, and Jalgaon. Gujarat, we had Jamnagar, Valsad, and Vadodara. Gulbarga, Mangalore, and Bangalore were in Karnataka, where we studied single person facility and polyclinic, nursing home, and multi-speciality hospitals. One district or one particular city where we had interviewed one pediatrician and one obstetrician from a single member clinic. From polyclinic, again, we interviewed pediatrician and obstetrician. Nursing home, again, we interviewed pediatrician and obstetrician, and multi-speciality hospital also. So we had 8 interviews in a city and 3 cities per one state, that counted 24 units per one state, and which totaled to 120 centers per 5 states. Inclusion and exclusion criteria were set, which were around the for on-site as well as online assessment, where the people from the associations who were the members were only selected as an inclusion, and those who were not qualified as obstetrician or pediatricians were excluded from the study. The study team consists of a national level IAPSM team, which had the people from various people who were part of this team across the country, who helped us to guide and who mentored this whole project. Then at the city level, we had a faculty who was an IAPSM member in a medical college. He was identified in this particular 15 cities, and he was entrusted with the responsibility of data collection in his city, along with 2 junior faculties to conduct the in-depth interview and the facility assessment. Data collection, what we did the pre-testing of the study tool at Mumbai. Prior approvals were taken from the facilities for pre-testing. Training of the team members were done at Delhi before the lockdown in January, and all the study team coordinators were called along with the national leaders from IAPSM. And then the study team adhered for FHI 360 and local IRB processes for pre-testing and finalizing of the study tools. The study domains which were identified, and then subsequently the study tool which was developed, which contained general information, knowledge regarding MIYCN, status of service being provided by the healthcare establishments, status of service related to MIYCN being provided at the private care establishment, human resource dedicated to providing MIYCN services, training status of the dedicated staff and availability of the training resources, hospital policies, willingness to provide MIYCN services, and challenges in providing MIYCN services were the major domains which were there in the study tools. The monitoring or the quality control measures were again done for the development of online survey, for having built-in checks and skips, and to ensure complete and timely submission of the survey forms and coding and analysis. IAPSM national team and site coordinator entrusted that all quality assurance measures were in place for all steps, including the training, data collection, data management, analysis, and further on the report writing, etc. IAP and FOXI national team ensured that all quality assurance measures were in place for all steps, including development of tools, data collection process through their networks, and contacting their members across the country for the online tools, as well as informing about participation on the on-site assessment. Alive and Thrive ensured that IAPSM team adhere to all quality assurance measure at every step of the research, and they were also talking with IAP and FOXI for their support and to build the partnership between IAPSM, IAP, and FOXI for this particular study. ethical approvals were taken from FHI 360 and the appropriate local ethics committee. The informed consent contained the information of the project, risk, benefits, confidentiality, payment issues, right of participation, and taking or leaving the study. Now, if you really see, this is how the study design and the study contents work. What will be the use of these study findings? So this was what we start, that this data will be used to identify the gaps in the practice and service provided around maternal, infant, and young child nutrition intervention in private healthcare establishment. A national level dissemination workshop with diverse group of stakeholders from medical college, developmental partners, health departments, and various associations can be also planned, and the data generated from this study can be utilized to design and develop capacity building models for the healthcare professionals, specifically with regards to obstetrician and pediatricians for private healthcare establishment. And this study will pave a path for further in-depth studies in the field of MIYCN in India. And this study can be a stepping stone for policy level decision targeted towards enhancing MIY services in the country. Now, looking at this, we conducted the study. We have completed the collection of online data as well as on-site data. The preliminary analysis is going on, and further to this, we are thinking, or we will be planning an dissemination workshop again in consultation with IAP FOXI, and we want the participation from IAP FOXI members also in that particular workshop, and we will be talking to the concerned people as well as madam. Your and sir, your blessings and your communications with your team will be of help when we disseminate the results of particular study in that particular study. But before that, just the preliminary findings, I would like to highlight, or I would just like to make few comments that the study identified few things, that is knowledge gaps were identified in private health professionals, inconsistency in practice is also observed, training gaps were also identified, availability of dedicated staff to provide nutritional counseling and other services related to MIYCN was also one of the important observations in the particular study. These were the things which were observed, and people have already informed in private sector that they really don't have the people at 4 levels, as we were talking about, a single person clinic, polyclinic, or a multi-speciality hospital, or the nursing home. But here we need to appreciate that they also mentioned that willingness to improve the MIYCN services were observed in, and provide quality care services was seen in majority of the participants. They also mentioned that there is a need for the refresher training, and they also mentioned a couple of challenges in the study which needs to be addressed at various levels. So this is what we have, this is in a nutshell what we have observed in preliminary findings. The detailed report, again, I emphasize that we will be presenting this within next maybe fortnight or month's time, with all the partners what we have, like IAPSM, which will be presenting, and then which will be with IAP FOXI members. All members will be invited for this particular dissemination of workshop, along with the developmental partners and the policy makers, and we will try to call the government officials also during this particular workshop. So thank you very much, madam, and over to you. Thank you.
I just want to have a comment on this. Really, it was an excellent work you have done. And I do agree that there are so many gaps because none of us, we all Foxy members. Yeah. Am I audible?
Yes,
Yeah.
yes, ma'am.
Yeah. So I always feel that these nutritional interventions definitely play a part. And all obstetricians are so busy that they don't have the time to talk with the patient and take the nutritional history and nutritional risk assessment and all those things. We have to train our Foxy members, as well as I think that this definitely will help. And I know that in each and every place, either it is a private sector or in the government sector, there is a different story, but there is a lack of availability of the dedicated staff. And we need to have this training off and on. And every time we tell that we have to include this in UG curriculum and PG curriculum. I work in the medical college, which is a private medical college. But in our place, we are having women's university. In women's university, there is a food and nutrition department, and I always take their services. And there are the counselors. We need to counsel the patient first, then take the nutritional history, then we plan for their nutritional diet or whatever the package is. And then we have to individualize each patient. For that, we have to have some time and patience. These things we have to develop, and I really congratulate for your efforts. And I would like to be a part of your workshops in further also. And I have also expressed my participation in the formulating of the e-module, which we can disseminate in all the obstetricians and gynecologists. And as a chairperson, Food, Drugs and Medico-Surgical Equipment Committee, Foxy, definitely I would love to be a part of these all your programs. I really congratulate for this survey. And maybe if you share me the pro formas and all, I would like to have in my place also, in my college, as well as in my Bijapur district. So how many, and I just want to compare from the urban practitioners and rural practitioners. Their ways of practicing are different, their food is different. And I recently did a survey of gestational diabetes and medical, this one, nutritional therapy in this one, gestational diabetes. And I found that the incidence in the North Karnataka is very, very less because of their eating habits. So maybe that creates definitely it causes some impact in our nutritional interventions in this high risk group also. So thank you very much. I would like to have comments from the pediatrician who is also there. I think we should start doing these nutritional interventions right from the adolescents. I really did 1,000 students adolescent survey in my place. Maybe I would like to share with Dr. Sankhe sometimes. I would take his number and mail him my data. Maybe he will help me in some something means to come to conclusion from where we should start. Not only the practice point of view, but the intervention point of view. I just want the comment from the pediatrician side.
Thank you, madam. Greetings and vanakkam from Tamil Nadu. Thanks for the opportunity provided by Dr. Shailesh and Dr. Amir Maruf Khan. So we know from the private sector, there is two extremes. There is a malnutrition and a malnutrition. That is the overnutrition. So in the private sector, we are seeing both aspects. So we have to keep that in mind. So as two states which have been really contributing to the national level, who are role models in the health sector like Tamil Nadu and Kerala, by their nutrition, education, counseling and social welfare programs, these two states have been role models for the entire India. And they have brought down IMR and MMR to a significantly lower level. So these models have to be taken care by proper coordination by the three associations which have come together in this platform by the efforts of so many stalwarts. The Indian Academy of Pediatrics, the Foxy and the IAPSM have to come together and they have to have a better coordination to cater to all the three levels, from medical college to the primary health center level to the sub-center level. They have to take the initiatives, whether it is government sector or the private sector. So I wish to emphasize important two basic things. One is the antenatal counseling of mothers, which is very, very important, be it in the private sector or in the public sector. So this is a period where the mother is receptive to all our counseling. And so there, all the three persons, a pediatrician, OG specialist, and a preventive care specialist, should go to the antenatal counseling in the public sector and as well as in the private sector. Private sector, it has to be taken because in abroad, we see that the antenatal mother is counseled properly by how the mother should take care of herself and the child to be born. So that forms the basis. So I'm going one step further, as Madam lastly pointed out, that adolescent counseling is very, very important. The adolescent are the core to bring out the next generation. They should be taught about the life cycle approach, and their care is very, very essential. So what my suggestion is, MYCN can be changed as MIYCAN, including the adolescents also. So these points I would like to stress, as that are the gaps which I would like to stress is, one is the antenatal examination of the mother for the inverted nipple, and take care of that, which is usually missed. And as the baby is born in the private sector, because of infertility and other things in IVF fertilization, the baby is separated from the mother. And for so many illness of the baby also, the baby is separated. So what happens is the breast milk is not given. So we have seen from the survey that only even in our state, though the institutional deliveries are 95%, only 50 to 55% mothers are giving exclusive breastfeed, and that too, colostrum is given very late. So in the private sector, we see that, especially in cesarean sections, the obstetricians also advise some other formula feeds, which we have been seeing. So I'm not blaming anyone. This is to improve ourselves. So we have to see that colostrum is given. Research has told that the early initiation, by giving as early as possible, even if it is a cesarean, you give it on the table. For a normal delivery, it is not a problem, even before the placenta is delivered. So this gives great protection in preventing sepsis and also for the well-being of the child. And they said for even the preterms, the nasal swabbing is coming in a large way. The breast milk banking, which is being nurtured in Tamil Nadu and other states, has come in a way so that even the baby and mother are separated. Human breast milk banking is coming in a large way so that the mother's milk is passed on, so that the preterm babies or the NICU babies are getting it. So we have to see that even during the first 6 months, exclusive breastfeeding is there is an obstacle because the working mothers, we have to see that in the private sector, even the working mothers have to have a side room or a creche or something like that. Or in Tamil Nadu, we can take the model. Say in government sector, there are 9 months maternity leave with pay. So the private sector has to be boosted so that they provide all the 6 to 9 months leave for the mother so that she can take care of the child. And regarding weaning foods, as suggested earlier, the biscuits and tin foods have still in vogue, which has to be avoided. And so the weaning foods have to be given a right choices. So what I would conclude is we have to have a better adolescent program so that we'll have a good mother and we'll have a productive, good baby with a good weight, and the baby will survive till the best, I mean, the first 1,000 days, as we have been suggesting. So with this, I would like to say that the right food choices in the adolescent, a good exercise, and the sunlight exposure, which is being not used properly in sunlight full in India, and the NCD prevention will pave a long way to see that the future is in bright hands. Thank you for the opportunity.
Thank you very much, sir. So it was a great presentation, and the best part is that now IAPSM, Foxy, and IAP, we are collaborating, and thanks to Dr. Lalit Sankhe for carrying this forward. Now I would like to move ahead with the next session. There are two sessions remaining. One is panel discussion, one is the paper presentation session. So the for panel discussion, I would like to invite the moderator of the session, Dr. Sebanti Ghosh. Dr. Sebanti has been very instrumental in taking this partnership of MIYCN, IAPSM, and IAPSM and Alive and Thrive ahead, and also supporting in the various conduct of the projects, also developing networking, and also the program and policy aspects. So I think I really admire Dr. Sebanti for the way she has nurtured this whole movement, I should say, and she is at the national level the director of the programs or the national level of for Alive and Thrive in India, and she has lots of experience in this particular field, the nutrition, mother, newborn, child, adolescent health across India and South Asian countries. And she has the skills and expertise, the policy and strategic program design, health system strengthening, capacity building, community participation, gender mainstreaming, and member of several national level technical expert committees of maternal, newborn, and child health and nutrition at national level, and contributed to number of national guidelines on RMNCH, nutrition, MA program, anemia, Mukt Bharat. So you name a program on maternal and child health nutrition, and she is one person to look out for. I invite you, ma'am, Dr. Sebanti, to carry on further with this panel discussion on quality in Poshan Abhiyan, prospects of implementation research.
Very good afternoon to everyone, and thank you, Dr. Amir, for such kind words of introduction. On behalf of Alive and Thrive, I'm taking a minute to say that I'm really thankful to the leadership of IAPSM, the way the MIYCN Technical Working Group became active, and the way the partnership between or amongst the three most important organizations, medical associations, IAP, Foxy, and IAPSM is shaping up. We are privileged to have acted somewhat as catalysts in Alive and Thrive, but we are really thankful to the leadership and the ownership that is getting demonstrated for ensuring that evidence-based MIYCN services reach all the women and the young children as they need it for a high quality of life. It is going beyond survival and focusing on quality of life. We have a very esteemed panel for this discussion. Will anyone in the team be able to share the screen for the panelists? I think I am having a little bit of, I'm trying to share. I hope it works. Is it showing up?
Yes, ma'am. It is going. Yes.
So this panel discussion is a very important panel discussion, and it is actually considering two very important issues. One is about the implementation research. We all know the importance of how we really need to use the art and science of implementation to inform program and policies, to ensure that they are delivered effectively, and we can make necessary changes in our policy and programming by understanding the context on ground, understanding the emerging needs. And this is what implementation research does. But this is a very growing, emerging area of importance where research is leading to action on ground. And for implementation research, what are we considering in this panel? We are talking about quality. So quality is a very important, very critical component that we really need to now, sort of think, breathe, live, sleep to really make the changes. Because without quality, we will not be able to achieve the outcomes of Poshan Abhiyan, make a difference in the nutrition and health status of our women and children. So I would really like to welcome Dr. Ratan Srivastav as one of the panelists. He has an illustrious career in the academics, with being faculty in various medical colleges in Gujarat, then in the Benares Hindu University, and right now he is professor and head of community medicine at Prasad Institute of Medical Sciences, Lucknow. And he was the president when Alive and Thrive and IAPSM began their journey. And he has been a pillar of support for moving things forward together. And he is a renowned community medicine person with multiple publications, and his contributions are well known in various scientific bodies that he has been a member at national and at state level. Next, I would like to welcome Dr. Sonu Goel, who is Professor of Health Management at the Department of Community Medicine and School of Public Health at PGIMER at Chandigarh. And his areas of specialization include international management development programs, operational research, and tobacco control. Next, I would like to welcome Dr. Alok Ranjan, who is currently the lead for nutrition at Bill and Melinda Gates Foundation for India, Bangladesh, Indonesia, and South Asia. And I take this opportunity to say that Dr. Alok has been the man behind the scenes, because it was with his support and our partnership with Bill and Melinda Gates Foundation that we had been able to be doing what we are doing as Alive and Thrive, including all the work that we have been able to do with the medical associations. So always encouraging, supportive, and he has been always in the journey that we, whatever, through all the ups and downs. And he was, prior to his role in foundation, he has been the nutrition specialist for UNICEF in the two key states of UP and Bihar. And he has over 15 years of experience in the areas spanning health and nutrition, covering research, polio eradication, routine immunization, child and maternal health, as well as emergency health and nutrition. So a warm welcome, Alok. And I think this is one of the rare occasions when you are not acting as the moderator. And you do that very well, and we will look forward to you equally being brilliant as the speaker. And then I have Dr. Sumit Malhotra. A warm welcome to you as well, as he is the additional professor at Center for Community Medicine at AIMS Delhi. And he has a special interest in health systems and operational or implementation research. So we really look forward to hear from you. He is part of the National IAPSM MIYCN Technical Working Group, and we really acknowledge the support, the active role that he provided to the work that was done in UP and Bihar with the medical colleges on the MIYCN curriculum and service delivery protocols. And the last but not the least, I am happy to welcome my colleague from Alive and Thrive only, Dr. Shailesh Jagtap. I don't know, I think the screen isn't being visible probably. Is it showing? I think I'm not able to see the screen. Is it working?
Yes,
Sure.
yes, I'm not able to see, yes.
It's all dark actually.
I don't know what to do then. Should I again?
Slide, go back to slide. Previous
Or 70, you stop.
It's come back. Is it visible now?
Yes, yes.
So Shailesh is currently the senior technical and program advisor in our team at Alive and Thrive, and he has been our nodal person for leading all the efforts with all the professional associations and engaging with the medical colleges for moving the MIYCN agenda. He is a MTPSM with more than 13 years of experience in implementing health and nutrition programs, with his domain expertise being in maternal, neonatal, child health and nutrition programming. He has been in other well-known international organizations prior to joining Alive and Thrive. He was with UNICEF, PATH, PHFI, and in John Snow, India as well. And I welcome you to Shailesh. I know he's one of the persons who has been behind the organization, working very closely with Dr. Amir and the IAPSM team. So let us start our panel discussions. I think I'm having some problems. I will stop sharing the screen right now because it's sometimes going blank. As you all are aware, we have 2 rounds of questions that we want to pose to you and hear from you and get your valued inputs, perspectives. So in the first round, we will be giving you 2 minutes to answer to that question. In the second round, we will be giving you 3 minutes each. In the first round, we have a common question for all of you, and that is, we really want to hear from you and understand from you, how do you look at the importance of implementation research, or having this implementation research approach being embedded in the programming so that we can really enhance or accelerate the Poshan Abhiyan deliverables. So I'll start with Dr. Alok to hear his views.
Thanks, can you stop sharing the screen, ma'am?
I had done it. I don't know whether it is not working. I had stopped it. I'm not.
Okay.
No,
Please go ahead.
Is it working now?
Yes. Now it is okay, so that I can see the panelist clearly now.
Yes,
Okay,
yes.
thank you.
No. Sorry for that technical problem. Oh, sorry, Alok, over to you.
Sure. Thanks, Sevanthi. And first of all, thanks to IAPSM and Alive and Thrive team for inviting. And it's kind of a dream come true to see the IAPSM have such a 2-day session on MIYCN. I would say Especially at a time in COVID when a lot of focus is going on COVID, and it's really exciting to see that working on malnutrition and talking about malnutrition has been given such a big priority at this point of time. On your question, since you just gave 2 minutes for the first question, I'll straight away jump into it. I do feel that it goes through a journey. It's from evidence to policy to action. So our set of implementation research can be looked across this entire continuum. Some of the research could be in terms of evidence creation. For example, if you look at the global WHO guidelines on MMS, multiple micronutrient supplements, it clearly says that country needs to go ahead in terms of looking at things from some more research to be done in the country context. So that's a very critical component that comes in. If you look at wasting, there it comes from the perspective that we know in South Asia, India, most of the wasting is driven by the maternal nutrition burden as well as the first 6 months where breastfeeding and other components comes into picture. And that's where we have to really tackle the wasting. So a lot of implementation research can go on these aspects where we need new insights and new interventions. Whereas if you look at things where it needs to go into the policy, I think that's where areas like, say, urban nutrition, adolescent nutrition, private sector engagement, there are a lot of things that can be done and evidence created from those perspectives. But I think in India, what is very critical right now, we have almost all the policies, we have almost funding available for a lot of these interventions across various programs, and the amount of HR resources that we have at the field level, like one Anganwadi, one Asha, one helper, and ANM every 1,000 population, and ANM for every 5,000 population. So policy, HR, and funding is not such a big concern. It's about the implementation, which is very critical. And glad to see the IAPSM conference for these 2 days really focusing on the implementation, what needs to be done, the how-to aspect of those. And I think in that third domain comes the things like, how do we now take the policy of maternal nutrition to better implementation? How do we work on the quality perspective? Because coverage is increasing, but how do we improve the quality? Similarly, household convergence. We know 1,000 days window of opportunity is very critical. How do we ensure all the nutrition specific and sensitive interventions comes and aligns in this 1,000 days window of opportunity? So I'll just stop there because we just had 2 minutes. Over.
Thank you, Alok, for some very useful thoughts to make us start thinking about the next steps. I would request Dr. Sonu Goyal to next share his thoughts.
Hello, everyone. First of all, I think I would like to congratulate all the organizers of this particular session, which is really important for our young researchers. I am on my way towards another meeting, so I just need to. I prefer switching off my video if I'm in my car.
Whatever makes you feel comfortable, or if Dr.
Yeah. So what I feel is, I think I agree with my previous speaker that implementation research is really important, and we need to actually promote implementation research in all the areas on the public health areas, and we need to move from our generic sort of studies, which are prevalence studies, cross-sectional studies, to more of implementation research studies, and we should have that culture of promoting those studies, especially starting from our postgraduate days. Because when we were students, we were exposed to only cross-sectional studies or prevalence studies. But now, as the things are growing up and new knowledge is being emerging, so now there is more of implementation research, and I have reviewed many theses and reviewed papers where more of implementation research is coming up. So implementation research is really important, and if we start a culture of doing implementation research starting from our college days, so this is really important. This is one. Second thing is about role of implementation research in the policy. So it is really important because implementation research is different from epidemiological research in such a way that it is done in operational settings, the actual settings where we are in. So when we do operational research, we find some problems, we find some challenges, and we can explore the solutions there and then, rather than a tight-fitted epidemiological or tight-fitted experimental research, where we may have solutions, but that solution may not work in the operational settings. So that is the role of operational research, because if we study some research on an area, whether it is food security or whether it is health system issues, so if we do operational research, then those findings the policymakers will gladly take in, because these findings will be are there in operational settings. The findings also tells about the challenges and the need in the in that particular area. So this is another important issue, that why we should need operational research in the area. The third point which I need to emphasize here is about the fact that where the operational research is actually happening now, right now. I think in most of the areas now it is now growing, and I feel after this this particular panel discussion and this particular conference, I think we need to put somewhere in the take home policy document to the policy makers, that we need to promote operational research in all the areas of public health where we are in. So I think that is the importance of operational research right now.
Okay, thank you. It's an important point that you talked about, orienting postgraduate students for implementation research. So I'll quickly move to Dr. Sumit for his views on the same.
Very good afternoon and greetings from All India Institute of Medical Sciences, New Delhi. I think it's very heartening that we have a session on a very important topic, and I think there is really so much momentum happening in this field, whether it's locally or it's globally. That implementation research has really gained a lot of popularity and importance. I think we all agree there is no dearth of interventions now. I mean, our intervention basket is really full. What is really important now to realize how to make these interventions work in the real life settings. And that's where the implementation research has an important role to play and offer learnings to all the program implementers, and the stakeholders that are there at various levels of implementation. So there is a dilution of effect that happens, when it comes to testing interventions in an ideal setting to taking at scale. So there are various actors, and these actors in a program setting, perform, at varying levels. So how to make them perform, to the best of their abilities and competence is something that we need to really learn. Now, there are several of protocols that have been designed, which have to be taken at scale. So implementation research has a role to play, and I'll kind of focus my talk to quality improvement studies, because the theme is to bring a focus on quality. And quality, one of the very important element is conforming to the standards. uh, Now there are quality improvements, cycles that are well designed in various aspects of practice, and there are one or two approaches which are very simple approaches, which are referred as PDSA approach, which is plan, study, do, act. And the another is basically AAA approach, which is assess, analyze, and act. Now what these approaches are, and which have to be integrated at various levels of implementation, they refer to finding out where the problems are. You study those problems, and because the entire approach is problem solving, you try to design some solutions to where we can improvise, and then you try to act accordingly, and it becomes an iterative loop wherein you have to continuously refine your cycles of implementation. So this particular approach of quality improvement now needs to get embedded into our various settings, now be it programs, or be it and the programs when get implemented at various levels, whether it's medical college level or the platform is a community or an outreach level. I mean, these things can be integrated. Now, I was hearing in the morning about that there are various now protocols coming for identification of at-risk, whether it's mothers or children, by offering a nutrition screening. So how these screening is going to be done by various actors, be it ANMs or Anganwadi workers or ASHAs, improving their performance through a systematic fashion, and generating an evidence and offering these learnings so that the other programmatic settings can work on these approaches, and then optimizing our coverage indicators of various interventions that we have rolled out. So implementation research has a lot to offer. I think there is a dire need that we inform various players to adapt and to develop a kind of ecosystem wherein this particular research gets integrated. Well, it requires a lot of collaboration and partnerships, and I think this conference is echoing that spirit, that you require so many collaborators to come and unite, so that this field can really grow and can offer to the betterment of future for next generations. Thank you.
Thank you so much. Very important point, really, to understand how the interventions are working on ground and what do we do to improve its performance. So very critical point. Dr. Srivastav sir, for your views and comments.
Yes, I think good afternoon, everybody. It's very, I think, nice to see all faces, even Dr. Alok, Dr. Sumit, everyone. They are looking so nice. And in the Corona period, I think this method is has made us possible to see each other. That's so nice. Because what I was thinking that most of the points are being covered. So I will not repeat those points. Yes, implementation. I was just thinking that the Poshan Abhiyan document has recommended formation of nutrition research centers. So can we plan of some NRC seeds? We can call it seed, jo beej hota hai chota sa. So NRC seeds in the Department of Community Medicine. So we can teach undergraduate students, and they know that there are some in our country, some nutrition research centers are there, and they know and they can help us. That is one thing I was thinking, that from a small budget in the department as an incentive, not much money is required, but we can create NRC seeds in the Department of Community Medicine, like daycare center in pediatrics department we used to create for ORS treatment. So there we can train our students, those who are there in the center, we can train them about implementation research. That is one thing. And yes, there are certainly like one trip method, trial for improved practices in the small group. So I think I will not discuss different methods. A separate group is required to sit and so that we can train people about this implementation research, and they can they develop confidence, and then they teach. Like one technique, PSBH in Surat, we have implemented problem solving based approach. So in that, undergraduate students used to take much interest. So certainly, perhaps it may also work. That is all I want to say. Okay, thank you. मैंने 2 ही मिनट लिए शिवांती, शायद आवाज नहीं आ रही आपकी.
Shivanti, you have to unmute. You are mute.
Shivanti, you have to unmute speaker mic.
Sorry, sorry. Sorry. Thank you, sir, for sharing some interesting and idea about moving ahead. We will come back to you again when we come to the next round of questions on how we can move ahead. So Shailesh, over to you for sharing your thoughts on
Thank you.
implementation research.
So first, let me highlight that when we're talking about this Poshan Abhiyan and implement research. So first, let's understand that nutrition is how multidimensional aspects are there. Multi-sectoral approach is needed. So with this aspect, you see an opportunity for implementation and opportunity for an implementation research at larger scale. So implementation research has I can say in this aspect, sky is a limit for implementation research component in Poshan Abhiyan approach. Now coming to the why implementation research. See, as mentioned earlier also, like in India, we have best practices or policies are there. We have interventions available. We have some best practices available which have been tested in a pilot setting, in a control setting. But when they go into the real field level setting, it's very challenging, difficult to scale it up and sustain it up. There are a lot of other examples in other field also, like IMNCA, and there are many other programs which are good programs in a pilot setting and in a small scale. So here is an implementation research approach with this new concept, as Sumit has mentioned on the PDSA, and different approach are there, which actually helps in understanding the field level situation and then modify the strategy, this approach, implementation approach. So there is an opportunity into this. And third point that I want to stress is, like, if you see, the nutrition program is implemented at the facility level, at the community level, at the academic level. So there are three different type of sort of platforms, and within the facility level there are different platforms: health, ICDS, agricultural, and all that. So now there are different challenges into it. How do those challenges, these program managers at the policy level, state level, district level, I will go down to the level. There are different issues in implementation. So this provides an opportunity for the researchers adopting the implementation research approach to test it and implement it, help in implementation through the implementation research approach. This is my broad thoughts here.
Thank you, Shailesh. I think using implementation research, to help us take evidence-based programs to scale, which have worked at in an ideal setting or in a limited geography, but how does that really work at scale? I think that's an important point that you have mentioned. We will move to the next round of questions. And so I go back to Olu, and I would like you to, reflect and share your views on which dimensions of quality you would like to prioritize for implementation research as part of the efforts of all partners to support Poshan Abhiyan.
Thanks, Evanti. So I would say for us to really make a dent on the nutrition outcomes, we used to look at from the C cube IQ, I would say, which is coverage, continuity, your convergence at various levels, intensity and quality. So fortunately or unfortunately, we do see in all the nutrition documents that since many years, I would say since decades, that we have to increase the coverage and quality. So increasing coverage is something that almost everyone has been prioritizing on. But if you ask the entire stakeholder ecosystem in terms of what does quality mean and what has to be done for improving quality, I think we'll have different answers coming from different folks. If you look at the RMNCH+A, a lot of MNCH related focus, family planning related focus on the quality has been happening for many years. They are way ahead of anything that nutrition community has been doing on the quality. So I think it's a high time. And that's why I feel very happy to see quality such high on the agenda on the discussion. I'll just draw on your question, I would like to take everyone back to what Dr. Pragya and Dr. Tanu presented, I think, in the quality assessment study. They very nicely and very comprehensively kind of looked at quality at various levels. Let me just call out a few which stands out for me and bring it from the Poshan Abhiyan perspective. The capacity building, where it is incremental learning, what is the quality of training that's happening? Is there any kind of a focus on the improving its quality? Because the poor the quality of training, the poor would be the implementation. What is the quality of supportive supervision? It is more like a monitoring by the lady supervisors and others, or it is going to the extent of working as a mentoring work. What is the quality of the community-based events, the Godh Bharai and Annaprashan days that are being celebrated? Are those just adding numbers, or they are really leading to, as someone raised the question, is it just coverage or just educating, or going to the level of being a counseling session in itself? Strengthening supply chain. We have been seeing that there is a huge focus under Anemia Mukt Bharat on ensuring IFA supplies. But is it available? Is it adequately available? And after giving it, like in terms of the routine immunization, we used to ensure the 4 key messaging, like what is it being given for? What are the benefits of this? When do you have to come back again? What are the adverse effects that you have to take care on this aspect? Are those things being done when IFA is given and being talked about? And just adding on top of this, any of this would not go a very long way unless there is data-driven focus on what is being done and looking at it from the data's perspective, quality of data, and more than anything else, the review of data. We know from the experience of polio and routine immunization that a district review mechanism happening very strongly adds immensely to what gets done at the field level. A DM asking questions is a huge component that gets added. I would end by saying that we have to look at quality from the nutrition system strengthening approach, just the way the entire world has been talking about a health system strengthening. I think it's high time that we look at nutrition from the nutrition system strengthening approach. And in that entire mechanism, when we look at from the nutrition system strengthening approach, many things would come out, but I think we have to focus mainly on getting the insights around how to do things done, what are the actionable components that comes out. And this will be very different for a state like Uttar Pradesh and Bihar versus a state like Tamil Nadu or Andhra Pradesh. It all has to depend on the absorptive capacity of the system to deliver as well. And last point is, let's not get the implementation research to get programmed into a kind of an analysis paralysis. It should rather be in a way that gives actionable next steps for the program to move ahead. So those were the few things from my side. I hope I covered in 3 minutes. Over.
Sorry, I think there is a problem in my system sometimes happening. But thank you for those excellent insights, Alok. And I think you have covered almost all the various important dimensions, starting from quality of training to quality of the service delivery, or the quality of supportive supervision to help improve performance, leading to the supply chain aspects, as well as the use of data to look at quality, because I think currently our data always do not focus on understanding quality. We look more at coverage. And then I think you summed it up very well about it's a system strengthening approach, and the system strengthening approach has quality at its heart. So thank you for that. I would now move to Shailesh. I think if you would throw some light on how would you be looking at framing the implementation research questions to understand, or what Alok mentioned about the various dimensions that need to be looked at. So how would you frame questions around some of these key dimensions, and that can be translated on ground to trigger action?
Right. Thank you, Sevanthi. So when we all know that any research, or now in particular when we are talking today, so it's about implemented research. Research question is the critical that will guide the implementation process. Because if our research question is wrong, research question is not relevant to the concerned people, concerned, then it may not be useful. See what is happening, like whenever a researcher, when I will first talk as separately as a researcher, whenever a researcher does a research, he thinks in terms of his interest and his understanding and what is his capacity or what he wants to do into it. That is perfect and fine. But then what happens, like when the researcher is thinking in his own lines, it becomes a publications and all that, but whether that research is being used for any action plan, for any program, that is a matter of question. So here when we try to reframe a question, we need to see what is the research question and who are the relevant people for whom this is important. For the based on that, a research question need to be framed. So point here I am making is that we need to engage in any research or any research activity. We need to engage the implementers. So these implementers, unless we involve these implementers in from the start, from the beginning, from the framing and then whole process, it will yield a result. So who are the implementers? The implementers may be the Angawadi worker, the ANM, the ASHAs, the block level officers, the district level officials, state level officials. So these are different stakeholders who are the actual implementers, and the implement research questions should matter to them. What is the priority research question, priority area for them? And when I'm talking about a system, because we are from medical colleges also, so the implementers also medical colleges are the implementers. If they want to integrate MIYCN into the curriculum or adopt the recent MCI competency based curriculum, so they will be also facing implementation issues. So what are these different departments need to be engaged together to identify the research question, and that will help in framing the research question. Now when I talk about the who are the key stakeholders, now how do we go about it? So consultations process see to frame the question, we data is also an important data. Based on data, which are the data that will help us in identifying the research question? So data from the HMIs, which is already there by the program implementers, data from the quality assessment or the monitoring activity that the different program persons do, implementers do, the quality assessment that we heard in the morning, that provides a different quality, you can say research questions can be generated from such type of this assessment, monitoring data, supportive supervision data. There are different data sources which will help us to identify the list of research questions. And again, last point I will bring, like a research questions, we have a research questions are there which may be relevant, but what is the priority, which are the priority research questions? Because we cannot take anything which is not maybe at present priority. So that priority has to be decided by the implementers. So we need to involve again the implementers to decide the research question and the priority research questions. So this is an important point, I think.
I think that's a very important point of the involvement of the implementers in framing the research questions, because they are the ones at the cutting edge of the service delivery or program delivery. And I think the audience of the research is important. How are we going to be using this, and with whom, and who is using it? So that defines the perspective very well. I would now move to Dr. Sumit to understand from him how he looks at, we often interchangeably use operational research and implementation research. So how does he look at these two definitions? Where do they come together and where they are different? So if we, please, Dr. Sumit.
Yeah, so there's an overlap, but yes, there is a distinction also. So when we look at this research area, operational implementation research, our setting is programs. So that are being implemented at various levels. So that is what is the
Oh no, Esper is gone.
The middle the focus. Around that, there are various. I think somebody has to mute Dr. Samina. Can you just mute yourself? Yeah. So so it is important to understand that there are, health system factors, and they operate at various levels. Now, to begin, the point of difference, we also need to, ponder about, there are various models of implementation, and I think the logical model is one which is critical to be brought about here. So we have inputs that go to, the program setting, be it financial resources, be it logistics and supplies, materials, manpower, because of which there are processes that happen. As Dr. Alok was mentioning, be it training, be it supportive supervision, be it, supply chain. So these are all different processes which have a bearing on the outputs that we have, number of trainings that happen, number of good quality trainings that happen, number of people acquiring competencies, number of sessions happening, say at a VHND platform, or in a clinic, how many sessions happening, how many clinics have supplies being ensured. These are the outputs, and then comes the outcome and the impact indicators. Now, when we are talking about operational research, this is a kind of a research category what is being said regardless of the methodology. So it is not very methodology specific. There can be variety of methods that can be used, be it qualitative methods or a quantitative methods, uh, 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 and what it aims at is affecting the coverage parameters, or the quality of the programs, or the effectiveness of the interventions. Now, what is the kind of point of difference between operational and the implementation is about the level that we are talking about. So operational is really local and very contextual. So it could be one district and a setting within the district, or it could be one hospital, I mean a small setting, or below those things. So the factors that operate there are very, very contextual, very, very local, which are going to be pertaining to that environment, that ecosystem in which that is happening. Now, so the factors that you want to vary operationally also will require some local approaches. So many of the things that we do, at a small scale level, wherein our healthcare providers are, kind of subjects of inquiry, and we want to, modulate the operations that are being done by them, by the various approaches, that becomes actually the subject of inquiry in operational research. Various things that you do in solving the problems at the local level. Now, implementation research, what is being said is that is one step higher or has a broader context. There is a degree of overlap, but then to make a point of distinction, is that it occurs, at a larger level, maybe a state or a country level, wherein the programmatic decisions are being made, and also the program managers are the users of the findings of the research. Now, classically, implementation research, would have a very important role to play in, suppose that we have generated an evidence of a new intervention, and now we want to introduce the intervention into various settings, in routine practice, and we want to generate evidence as how this can be rolled out, and what lessons can be drawn, so that when we are taking up to the scale, uh, 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 you know uh, how it can be done very nicely, so that the adaptation of program components, or the delivery mechanisms that is going to be done in rolling out an intervention, can be done in a better way. Now, there are various behavioral interventions also. Say, for example, now in a COVID era, we are talking about the training modalities. So can we introduce tele-mentoring approaches for our ASHA and Anganwadi workers is a critical implementation question, because you can't have face-to-face trainings in a situation like this, wherein social distancing, physical distancing is a norm, and in a training face-to-face, there are challenges there. But all of our stakeholders require exposure to refreshers and also newer things that they have to be done. So can tele-mentoring mechanism for these ground level functionaries, can it perform equally to face-to-face training in performance indicators? So is a critical implementation question, right? Now, the operational question could be, say, for example, once you've already trained, now we know that our VHND platforms, as being also pointed out earlier, now we have very good kind of protocols and procedures in place, but then they just become the platforms for health education. Well, that's not just the only thing that we want to deliver. So how can we actually, make our providers, really touch upon the various aspects that should be implemented is a critical operational question, and will require a little more hand holding to the local setting. So what is going to happen in UP and Bihar is going to be very different in Kerala and Tamil Nadu. So because the context is very, very different over there. So these are what comes to my mind when it comes to making a distinction between operational and implementation. Going one level higher is actually the health system research, which really talks about the building blocks, talks about the policy, governance, leadership, and things like that. So it gets more complicated. But just one question I would like to touch upon, to reflect upon, is that the government sometimes have a critical question to answer, that can mid-level healthcare providers, in current scenario, can they really take up many of the roles that we want our doctors to play, because doctors always are in shortage, but we want villages to be served. So can we look for some other providers to perform the same function? I mean, it's a policy level decision, and then what kind of providers are we looking at? So I think these are the various facets when it comes to in a continuity, the operational implementation and health system research. The ultimate goal of all of this is to improve the performance, improve the coverage, so that the best outputs, best outcomes are achieved at the end. Thank you.
Thank you very much. I think you summed it up very well with the operational research and implementation research and moving into the health systems research. I think that goes back to what Alok was mentioning about nutrition system strengthening with quality being at center. So that's the systems research, and with a focus on quality, embedding it in that systems research is something that we really need to consider. I would now yes.
Just one comment. I would comment or addition I want to give on this, if you're fine.
Okay.
Right. See, the implementation research actually gives an opportunity to identify solutions, test it, and if not being implemented, there are challenges, and identify alternate solutions. So it helps to identify through a series of maybe identifying the problems, identifying solutions, alternate solutions, till we reach the stage of implementation. So this is one important component that I think.
Yes. And the content that we have been all talking about, it has to be very contextual, the way we are getting the solutions, understanding the barriers, challenges, or the enablers. So now I would request Dr. Sonu to talk about something slightly different, but very linked to it, that how does he look at the capacity building of IAPSM members in the various states on implementation research, what kind of a role the state leadership can play to bring to fore the concept of implementation research among its members, and even think of doing state-specific implementation research which helps the state systems to deliver better. Dr. Sonu?
Yeah, thank you, Dr. Sivanti. Yeah, actually, I will take this thing forward with this conference, and I think this conference is the first step. What at the national level you all are doing. So I think we are already moving at the national level and taking this implementation research and operational research as the key area, and we should focus on it. So I think this is the step in right direction. And similarly, we should have such sort of state level conferences, state level meetings, state level workshops, which focuses on implementation research. And we have few models for it. Like I think Dr. Sumit has also done some work on operational research in his settings. And even we have at PGI, we have developed an operational research model in which we invite people from different medical colleges and work on certain research questions. And then people work in their own departments, in their own states on those research questions. And then we invite them again for paper writing. And again, so this sort of things happens. So I think these sort of operational research trainings should also be done besides the conference and the workshop in which we orient these people on operational research. So these are the two things. Third thing which we can do at the state level is having more of advocacy with our policymakers. Like policymakers are not aware about these sort of research. If we engage them in operational research, as we always say, that operational research is a marriage between the implementer and the researchers. So unless one person is cordial enough with the other, that marriage will not last. So we should have that good gel between implementer and the researcher and the policymakers for getting this implementation research. And for that, we need a very good advocacy at the state level. And we have sufficient funds in the project implementation plan, PIPs. We have already utilized that thing in the state of Punjab, Haryana and Chandigarh, that we get the fund for operational research, not only for tuberculosis, but also for other diseases, many other conditions. So this is the third thing. Then fourth thing, which I want to really emphasize upon taking newer aspects in operational research. We always, Dr. Alok, Dr. Shailesh, and Dr. Sumit talked about some of the aspects on training and related to operational management. But I will talk about a few newer things in terms of the topics we should take. Like the emerging topics which are coming up. Like if we talk about Poshan Abhiyan, the emerging topics are like trans fat issues, so which is really coming up right now. So second thing which is really important is the reduction of salt. We have actually focused on like saturated fats, physical activity for so long, but now we should focus our area more on super specialization topics, which we talk about. We have super specialization in other disciplines. Here also we should move our topics into that particular nitty-gritties, that we should take these topics which are really more essential, like taking trans fat issues, taking these salt reduction issues, taking some more micro topics. So I think we should do more research at the postgraduate level on these particular areas. And I totally agree with Dr. Sumit that these topics are really important at if we start at the grassroots level, and we should keep on orienting people not only at the policy level, but also at the, because operational research, if we talk in a general language, we can always teach ashas in what operational research is. So we don't have to actually work very intensively. That operational research is a very because when we were postgraduate students, we were told that operational research is about mathematics. It's about mathematical analysis, about lot of formulas, lot of jargons into it. But when we get an insight about it in some trainings and all, so then we got that operational research nothing, but we are evaluating whatever there is going in the systems, whatever real challenges is. And as Dr. Shailesh has rightly said, that like we keep on finding the challenges, we keep on finding the opportunities, work on those opportunities, and then we find out the solution, and then we keep on working on those areas. So I think these are the 4 or 5 areas where we should keep, where our state chapters, zonal chapters, and our national chapters should keep in. And just to conclude, that like all IAPSM conferences which we are holding at the national level and the state level, we should keep this operational research workshop as we have been keeping it, and I think Dr. Sumit has been doing it. But we should keep this practice of keeping operational research workshop at these forums. So that's all from my side.
Thank you. Some very useful suggestions. And I think the linkage that you spoke with the government, with NHM and harnessing, NHM funds, I think that becomes a very co-owned process where the implementer is able to define the requirements of the research, of understanding problems and finding solutions and testing them, as well as the medical college, the IAPSM community coming in with their expertise to help with that kind of improvements in program design and delivery. I think that your experience should be something that is taken up and maybe also already happening with other state chapters and colleges, but it would be my request that we, do it at a larger scale. And this momentum is built around where medical college is, the community medicine faculty, IAPSM really is supporting the system to deliver better. And now, Dr. Srivastav sir, to you for your expert comments on how you think IAPSM really can move ahead in the days to come, building a culture of implementation, research, and at scale. How do you see the role of IAPSM would evolve, prioritizing implementation, research, and contributing even more significantly to Poshan Abhiyan and other major public health nutrition programs in the country? Over to you, sir.
Thank you, Dr. Shevanti. You have given me very clear-cut topic for speaking, and it's very interesting to me also, because I have been in Department of Community Medicine for last 40 years. And now, at present, I'm participating in my second session of community medicine. Means after retirement, I have joined a private college, and I'm seeing a different environment, very challenging. A lot of things has to be developed. So my first observation is throughout my life, means of 40 years, that many students, many faculty, they do not know importance of research. Means by doing research, sometimes they think it's another burden over us, and means it requires a lot of computer work or a lot of IT knowledge and other things. They do not know the benefit, real benefit. Like sometimes I have told undergraduate students that if you develop, or if you do good research during post-graduation, like in clinical medicine, many times they just complete thesis work just for submission. And faculty sometimes say that, I remember when I was doing PG, one of my colleagues says that it is a passport that you have to submit, and then only then you can appear for your practical examination. So many students say different versions. Dr. Sumit is younger one, so he may give me some latest terminology that what people say about submission of thesis. So what I feel that we must educate every faculty member, not only IAPSM, many faculty members, they are not aware. Only few who have excelled in research, they enjoy, they travel. Like I used to say that if you maintain good quality, good methodology and standard collection of data, then your foreign visit is certain. I used to say this. And otherwise you will do a lot of private practice, you will collect money, and then you will go to foreign country. I used to say, okay, you do good research, people will invite you, they will fund your stay, they will fund your airfare and everything they will fund if you do good research. So I think lot of information, so we can plan for that, how information can be passed to each and every faculty member. This is first point, I think. And second, some recognition award. I think IAPSM gives an award, but they give award to only one paper or two paper. If there are 800 delegates. So majority of people they miss. So they do not feel some encouragement. So we have to devise some methodology. At least we cover some 100 people, 100 students at a time in one conference, minimum 100. How means that we can decide. So means otherwise you encourage only 3-4 people. If you see, I have seen that in my department there were 5 PG students. I just appreciated one because she was doing very good. All were girls. So I'm not mentioning the favor of boys and girls. So all were girls, but I appreciated work of one girl. Later on, because all 5 girls were excellent, they all approached me one by one. They said, "Sir, आप हमें बताइए, means how I am not so good in any work. So I faced that problem. So then I started appreciating each and everyone. But anyway, we have to develop some technique, and people they excel. Second thing, while recognition, many times a clear-cut favor is done. So we can develop some technique that some methodology, so we can avoid that thing. I think we all are human beings. We are not computers, so little bit may happen. Then, like I have served in state medical colleges for 25 years, and then for 12 years in BHU. What difference I have noted? While serving in Surat, in Gujarat, the publication was not such a serious issue. Yes, I have taken interest. I could publish many. I think Alok was my student over there, and he may recall that we were not mad and we were not after that. Even sometimes our head of the department used to say, like when you do some investigation in field, and he or she will say that it will not be published. It is not for publication, your field work. On the contrary, but in BHU, there our vice chancellor will conduct meeting with every faculty member, will say, we must publish best article. Let us make our university number 1. Let us make our institute number 1. Then our dean and our director will make meeting. He will be very serious. He will call every faculty member. And such type of meeting I have never seen in Surat Medical College, that in state medical college. Perhaps such meeting is required. Such orientation is required. And let me tell you that in 25 years, I could publish only 25 or 30 papers. And in BHU, instead of 12 years, I could publish 50, 60 papers. Means I had to control it. So that difference I could see. So it was, I'm just sharing my experience that how can we promote the department for, then certainly for promotion, MCI has said only 1 publication to become associate, then 2 publication. I think this is too less. And I remember Gujarat, that our commissioner, Amarjit Singh, he was IAS, when he used to interview, when somebody appeared for professor, and he used to ask like, what is this type 1 error, type 2 error, what is sample size? So professors, they were not able to answer. Because he did MCH from London School of Hygiene and Tropical Medicine. He met many professors, and he saw that they know too much statistics, they know too much research methodology. So he was feeling sorry over there that people are not much aware about research methodology. So I think some culture has to be developed, and we can start from IAPSM. Then another, sometimes financial gains, like so we have sometimes indirect financial gains may appreciate, but awareness is important, like travel abroad. And I used to say the younger assistant professors, if they are doing research below 35 years of age, the international body usually invite them. And then senior, if you become, perhaps they do not spend money. So yes, that is all. I think it's a very big topic. I cannot speak at a short interval, but it's a thought. Only one thing, because Dr. Shebanti Ghosh is here, Dr. Shailesh is here, and Dr. Alok is here. The reason is that we are going to organize a state level conference over here in our institute, this Prasad Institute. So I invite and I request these 3 big agencies to have one session over here on implementation research. Our dean our principal is Dr. B.K. Srivastava from my subject. He has asked me that I told him that I am going to, he has asked me. And I think this is a good opportunity because for whole Uttar Pradesh, I'm going to have conference either virtual that many people will attend through online, and I think 50, 70 people, maybe 100 people will come because government will not allow for a large gathering. So our conference dates are 12th and 13th December. So Dr. Alok, please think on this issue, and I can phone you later on, Dr. Shailesh, Dr. Shevanti, and Dr. Sonu is was highlighting this issue that at the state level, this should be given some importance. Thank you. That's all.
Thank you so much, sir. And I think the session has been very stimulating and very useful insights have been shared by all the esteemed panelists. And I thank all of you for your active participation and for this really thought-provoking session. I won't say further because I think we are anyway running very late. So thank you once again, all of you. And over to you, Dr. Amir.
Thank you, ma'am. This was a very interesting panel discussion that was going on. And I think yesterday also when we started discussing about research, implementation research came up in a big way. And today it moved ahead further. We took the discussion ahead. So thanks to all the panelists and ma'am, the moderator. So now we will move on to the last session of the day. And I would like to invite our chairpersons, Dr. Joshi, Harishankar Joshi, and Dr. Manish Singh for this paper presentation session. We had around 25 papers, this abstracts we got, and out of that 4 will be presented as oral papers here, and simultaneously between 12 to 1:30 it was the poster presentation session was going on Google Meet. So that is over, and here we are with the paper presentation session. So Dr. Joshi is presently working as professor and head community medicine and family medicine and is research coordinator at AIIMS Gorakhpur. He has lots of experience teaching and publications in various international journals. And he is also a medical educationist to the core, I would say, because he, as you can see, he has also done his FAMER fellowship recently, and also published so many articles in various journals. I would like to add that sir joined WHO after post-graduation, and then teaching attracted him, and then he came to teaching, and he has stood by teaching as a rock, as steady and promoting many students. And whenever I meet sir's students, they always praise him a lot. So thank you, sir, for joining us.
Thank you. Thank you.
Thank you, sir. And we would like to invite the next chairperson of the session, Dr. Manish Singh, a close friend, a colleague. Dr. Manish Singh is, you can see all the awards. I think almost all the awards that are there, he has it. So I think it speaks a lot about his multi-faceted personality and multi-dimensional approach, and good academic and good organizational skills. You can see it is reflected on the slide as an ex-president of IAPSM UP UK chapter, a secretary of health education of the national IAPSM body, and also with Consortium Against Rabies. He was the vice president earlier, and he has been a national trainer and resource faculty in various workshops related to IYCF and MA programs. And he is along with us in MIYCN group also, and also as a project coordinator in nutrition related programs at the field level. So I welcome both the chairpersons, and I hand over the session to you both for the paper presentation session. Thank you.
Okay, thank you, Dr. Amir.
Thank you. Thank you, Dr. Amir sir.
Good afternoon, Joshi sir, and good afternoon all participants. Am I audible? Hello, am I audible to you?
Yeah,
Yes, you are audible.
Yeah. So, Dr. Amir sir, can we start the presentation? We can call up the first participant for the presentation.
Hello.
Hello. Hello, Dr. Amir sir, can we call up the first participant to present the paper?
You
And,
might be having the names, Dr. Manish.
Yeah, okay. So the
You
first
can call and
participant,
they will present,
okay.
and they can present from their screens, or
Okay. So
you can help. Okay.
the first participant is Dr. Priyanka. So now I invite Dr. Priyanka to go ahead with the presentation. So you have around 6 minutes to present, and followed by 2 minutes for question and answers. So Priyanka, are you there? You can unmute yourself. Dr. Priyanka. Okay, so the next participant is Dr. Samina. So in the meantime, if Dr. Priyanka is not here, Dr. Samina, are you there?
Yes, sir. Yes, sir. Hello, yes, sir. Yes,
So,
sir, I'm there. I'm Dr. Priyanka. I'll
okay,
just
so
start.
okay, just start your presentation.
Poshancon. Good afternoon, respected chairperson, panelists, and everyone over here. The topic for today's presentation is Association of Antenatal Breastfeeding Counseling with
You
duration
can make it full
of...
screen, Dr. Priyanka. Please make your presentation to
Yes,
full
sir.
screen. Share your full screen.
Niche se down, down, go down. Yeah.
Yes, done.
Done.
Go ahead. It's done.
Good afternoon. Okay. Thank you, sir. Good afternoon, everyone. Today, the topic of my presentation is Association of Antenatal Breastfeeding Counseling with duration of exclusive breastfeeding among infants in rural area of Haryana. The first 1,000 days of child's life, starting from conception through age 2, is crucial period for ensuring child survival, optimum growth, cognitive development, and healthy life. To breastfeed an infant successfully, breastfeeding counseling plays an important role. So the objective of the study was to evaluate the effectiveness of antenatal breastfeeding counseling for increasing breastfeeding initiation and duration. So we had done a community-based cross-sectional study, which was conducted in the rural area of district Jhajjar, Haryana, which is a rural field practice area attached to Department of Community Medicine, Pandit B.D. Sharma, PGIMS, Rohtak. The study was conducted over a period of 12 months commencing from March 2019. All the infants aged 6 to 11 years who had completed 6 to 11 years and their mothers were the study population. Taking the prevalence of exclusive breastfeeding in Haryana to be 50.4% as reported by NFHS 4, and taking the allowable error of 15% of the prevalence, the sample size after calculation had come to be 178. So the purpose of the present study, we had selected 200 subjects were enrolled in the study. It was a multi-stage sampling. All the 5 PSC, which comes under CSC Deagle, and all the 20 sub-centers of these 5 PSC were selected for the study. 2 Anganwadi centers selected randomly by lottery method from these sub-center area. That is, there were 20 sub-centers and 2 Anganwadi centers from each sub-center area. So total 40 Anganwadi centers were enrolled. The list of infant aged 6 months to 1 year of age was prepared from each of these Anganwadi, and out of the list, 5 infants were selected by simple random sampling technique. Data was collected using pre-designed, pre-tested, semi-structured schedule comprising questions related to antenatal, perinatal, postnatal period as well as maternal and family characteristics. So about the results, out of total 200 lactating mothers, 79.5% were giving antenatal breastfeeding counseling. 97% mothers were of the age group of 18 to 35 years, 93% were literate, 83% belonged to joint family, 88% had 1 or 2 children, 81% had normal vaginal delivery, and 88% of women had 1 or 2 children. So this table shows that among the breastfeeding, we had divided into 2 groups. The one group, among the group of women given antenatal breastfeeding counseling, 93.1%, 93.1%, 91.8%, 88.1%, and 72.3% were given only breast milk at 1 week, 1 month, 3 months, and 6 months. And this association of type of feed with the breastfeeding counseling was found to be significant in all these 4 time periods. About when we applied the logistic regression, we had seen that the women who were given breastfeeding counseling were 4.3 times, 4.1 times, 3.8 times, and 2 times more adherent to exclusive breastfeeding at 1 week, 1 month, 3 months, and 6 months respectively. Now about the factors associated with antenatal breastfeeding counseling. So the table shows here that among the women who were given breastfeeding counseling, 80.7% of women had given the first feed as breast milk to neonates after birth. 82.5% had given breastfeed within 1 hour after birth. But burping was practiced in 81% after breastfeeding. 79.7% were giving breastfeeding at night, and 65.4% were motivated to breastfeeding till 2 years of age. Yes. So here we see that it was observed that the antenatal checkups were directly linked with the counseling, breastfeeding counseling in women. With more antenatal checkups had more breastfeeding counseling, and this association was also significant. The antenatal breastfeeding counseling was administered 1.6 times, 2.7 times, and 2.1 times more to women who had 3, 4, and more than 4 antenatal checkups respectively, as compared to women who had only 1 or 2 antenatal checkups. So in this, here we see that mother's literacy level also played a significant role with the antenatal breastfeeding counseling, and this association of mother's literacy level with the breastfeeding counseling was found to be significant, and more than 60% of the women who were given breastfeeding counseling were educated, had the education of higher secondary, and they were graduate. Thus, my conclusion is, thus we have seen that antenatal breastfeeding counseling plays an important role in exclusive breastfeeding. For administration of antenatal counseling, literacy of mother and antenatal checkups play a significant role. In community awareness about exclusive breastfeeding till 6 months and continuation of breastfeeding till 2 years should be advocated. The limitation of the study was the quality of breastfeeding counseling was not assessed in this study. Thank you, sir.
Thank you, Dr. Priyanka. Now the presentation is this is open for discussion among the participants. If you have any questions. The participants, you can go ahead with the. Are there any questions? Okay, so if there are any questions, you can put them on the chat box. I would like to ask you a few questions.
Yes, sir.
Yeah. If you go back to your objectives. Can you go back to the objective slide?
Slide. Slide बताओ तो कहाँ है? Slide
Okay.
Slide.
You can
yes,
just listen. I just noted it down.
Okay, sir.
So your objective says that you wanted to evaluate the effectiveness of antenatal breastfeeding counseling for,
Yes.
yeah.
Yes, sir.
Okay, so go to the objective slide, the where you have mentioned the objective. Okay, so here the objective is, and you have written that objective was to evaluate the effectiveness of antenatal breastfeeding counseling, okay, for increasing breastfeeding initiation and duration. But if you see at the results, what I see is most of the results are focused on, if you go to the result one, slide one, go ahead with the change the slides. Go to the, okay, now this result is, do you think they are in line with your objective? Like you're looking for association here. What the objective was to evaluate the effectiveness of antenatal breastfeeding counseling. So
Yes, sir.
how do you defend yourself here? Like,
Sir, in the objectives, I meant for, I had divided the 200 study subjects into two groups. Like one group was given antenatal breastfeeding counseling, and the second group was given no counseling. So had received no counseling during the antenatal period. So during the field visit, we had asked we had the questions like
but
type
you
of feed given for 1 week, only breast milk and mixed feed or other feed. So for the duration,
what was
sir.
pardon me for a moment, like if you go to the methodology, I think you have mentioned it as a cross-sectional study,
Yes, sir.
isn't it?
Yes, sir. It is a cross-sectional study.
So but now what you are saying is appears to be an intervention, that you are giving counseling to.
No, sir. We had asked. We had in the study subjects, we had selected the infants and their mothers who were 6 to 11 months old, and we had just asked. We had the questionnaire. In that, we had asked that whether the breastfeeding counseling was given or not. To take out the effectiveness of breastfeeding counseling, we had divided.
Okay, so can you assess the effectiveness? Can you evaluate the effectiveness of any particular intervention, like you're mentioning antenatal breastfeeding counseling? Using this study design, is it? I don't think it's appropriate. Like you are going for a cross-section study, and secondly, you are most of your slides, the result part, you have focused on the association. Like you have
Yes.
looked for what association.
Yes,
Okay,
sir.
but I was expecting from the objective that you'll go with some, like you have done some intervention and you're going to see it. Secondly, if you see, okay, now how did you define counseling? So you have mentioned already in the limitation that you didn't access the quality of counseling. Okay, but whether the woman received counseling or not, how do you define counseling?
Sir, sir, in the counseling, the mothers were asked whether the ANMs who were doing the checkups in the field, who were giving the antenatal checkups, they had given the counseling, or they have encouraged them about the benefits of the breastfeeding, about the duration of the breastfeeding, about the drawbacks if they don't breastfeed an infant. What are their drawbacks, and why should they breastfeed the infants for 2 years, or say exclusive breastfeeding for 6 months? I had asked that whether they had given such type of they had received such type of counseling in their antenatal checkup time period by the ANM or any healthcare worker.
You have just taken a history whether the
Yes, sir.
participant had received counseling or not. But
Yes, sir.
okay,
Yes.
so I would okay, I congratulate you that you have taken up the study on this very important subject of MIYCN, first of all. But there are few suggestions or few things which I'd like to suggest you here. First of all, when you decide a topic, the topic and the objective should be in line. Okay, so and then the results and whatever things, conclusion and recommendations you say, they should follow, they should be in line with your objectives. So what I see from your presentation is your objective says something and the result section speaks of something different. And when it comes to your conclusions and recommendation, they are again not in line with the results that you have. Okay, so the recommendation, when you say, it needs to be very specific, like whom you are giving the recommendation, what you are expecting that particular agency or that particular sector to perform, what they should do, right? And so these are some of the findings I could collect from it. Okay, so you can improve upon this, and so it was a nice presentation. Thank you so much.
Thank you so much, sir. Thank you for your
So
valuable
Joshi
suggestions.
sir, if you want to ask anything, Joshi sir, if you want to ask something. Joshi sir, are you here?
Hello. Hello.
Yes.
Okay.
Yes, sir. Yes, sir. Good afternoon.
Yeah, sir, you want? Sir, you are audible.
Yeah. Hello.
So you want to ask any questions?
Yeah, Dr. Priyanka, you have a very nice this thing. Your topic is very nice. Okay, and the presentation, your way of presentation also was very good. But as Dr. Manish suggested, alignment is slightly different, but you can improve in a better way in future. Okay.
Yes, sir. Yes,
Best
sir.
wishes.
Best Thank you so much, sir. Thank you, sir.
Best wishes for you.
Thank you.
So now we can. So now I invite Dr. Samina. Dr. Samina, are you here? So you can go ahead with the presentation. Dr. Samina. The next participant is Dr. Swapna. If Dr. Samina is not ready, Dr. Swapna can go ahead.
Yes, sir.
Dr. Swapna, are you here?
Yes, sir, I'm here.
Okay, so you can start your presentation.
Yes, sir.
And the next presentation will be by Dr. Samina, and that is to be followed by Dr. Trishna. So I request the next two participants also to be ready with their presentations.
Good morning, sir. Let's start, sir.
Good morning. Good morning.
Good afternoon, sir. Shall I start, sir?
Yeah. Start. Please carry on.
My topic of interest is a study on awareness and utilization.
Your slides are not visible, Dr. Samina. Slides. Hello.
Yes, sir. I am connecting, sir.
Your slides are not visible.
Slide share is there, no? Video is not, host has stopped.
Video is not started. Okay. Good afternoon, sir. Good afternoon.
Yeah, good afternoon. Can you show your slides?
1 minute, sir. Is that visible, sir?
No.
Ma'am, open your presentation first, then click on share screen, that green button, and then select the presentation. Yeah? Have you already opened your presentation, ma'am?
Yes, sir. Okay.
Then click on the share screen button and then select that.
Should I do for her?
Yes, ma'am.
Hello?
Yeah, ma'am, I think in the interest of time, please go ahead. Yeah.
Yeah, now it's visible.
Yeah. My topic of interest is a study on awareness and utilization of the government scheme on maternal nutrition in urban women in Telangana.
So you can go ahead.
Yeah, yes, sir. I'm coming. An introduction. 1/3 of the Indian babies are of low birth weight, less than 2.5 kg.
You skip introduction, curve, aim and objective directly. Skip introduction. Aim and objective.
Yeah. Aim is to know the awareness of the supplementary nutrition program supplied by the ICDS project to the public. My objective, sir, to enhance the quality and acceptability of the maternal nutrition and child nutrition, and also to ensure that the ration provided is available to the mother and not for all the family members, and for reducing the infant mortality rate and maternal mortality rate. So my method is a total of 50 urban pregnant women were randomly selected, and majority of the respondents belong to the age of 18 to 42 age groups. The data was collected through personal interviews with the help of the structured schedules and was analyzed using standard statistical tools. My objectives were to enhance the quality and acceptability of the I'm sorry, sir, I'm panic. And my results objectives to decrease the anemia in maternal and children, and the results are on socio-demographic status. Most of the age group between 18 to 25 years, which is 52% of the women are in the age group between 18 to 25, and 28% are between 26 to 30 years, and 20% are between 31 to 40 years. And education awareness on this program, ICDS program, that is illiterate are 76% and primary education of 14%, out of the secondary education of 10%. And below poverty line and above poverty line are utilizing this ICDS project program. And in the occupation, housewives are 30% and moderate workers are 50% and vigorous workers are 20%, under which the ICDS programs are beneficiaries by the women. So beneficiaries, the present study shows that 100% of the Telangana people are aware of the ICDS project, but only 80% are beneficiaries of the respondents and they felt these schemes were good. Telangana is sharing, in Telangana, the ICDS project was changed to a theme known as Arogya Lakshmi, and these are about 31,897 and main Anganwadi centers and 4,076 mini Anganwadi centers are working all over Telangana, and this is a modified scheme of Amrita Hasam. So Telangana share in the nutrition program is highest in the country, and 80% cost of one full meal is borne by state government. Take home in the ICDS project, take home ration was given, but it is not sufficient, and it is also shared by all family members. So it is changed one full meal program, spot feeding with one full meal program, and that the meal contains of rice, dal, green vegetables, leafy vegetables, and one egg, boiled egg, and 200 ml of milk for 25 days, and for 30 days. And then for 30 days, the food is supplemented to the on this spot feeding. And in Telangana, there are people share in the nutrition program is highest in the country, and 80% cost of one full meal is about, and the one full meal provides 40 to 40% of calorie requirement and 40 to 45% of protein and calcium requirement to the mother. And this also includes reduction in the anemic anemia in the children and maternal mothers, and so reduce the infant mortality rate and maternal mortality rate. It can be said that this scheme should be run across India, and majority of the people gets benefited. Mother malnutrition can, because of malnutrition, low birth weight babies and underweight children and mother with anemia are beneficiaries, and they are reduced in the reduce. Thank you, sir.
So, thank you, Dr. Swapna, for the presentation, and I am thankful. I really thank you for taking up interest in doing this study on awareness and utilization of government schemes on maternal nutrition, for your interest in this field. So now this presentation is open for question and answers. So any participants, if you want to ask anything, any question to the presenter. I cannot see any questions in the chat box. So Joshi sir, would you like to ask something? Hello. Joshi sir. Hello.
Hello. Yeah, hello.
Yeah, would you, sir, would you like to ask something to Dr.
Yes.
Swapna?
Yes, Dr. Swapna, your study is very nice. Okay, your study means like study the awareness. You are postgraduate student, na? This is your thesis part or what?
No, sir. She's always PG, sir.
You passed your PG year.
No, sir. Final year postgraduate.
So this study is your thesis part, or you just?
No, sir. Not thesis topics. Not thesis topics, sir.
Okay. So Miss, like in between your presentation was disturbed because of this thing.
I was from the introduction. I was prepared. You told to skip this introduction, so I was confused, sir.
You may be confused. No problem. But actually, mainly we are just want to know your objective and what are the studies.
Yeah.
So, Miss, like how you chosen this topic? Miss, like what came in your mind to choose this topic to study the awareness?
And then that is my own thoughts, sir. Study the awareness about Anganwadi centers providing this supplementary nutrition program.
That how and why this topic came to your mind to study?
I'm a PSC medical officer, sir. I worked for 14 years as a PSC.
Okay, okay. Therefore, you thought that you now you joined public health and you try to study what is the awareness and utilization.
Yes.
Okay, then carry on. Dr. Manish, if you want to ask,
sir. Yes, sir. Dr. Swapna, actually, I would like to give you some of the points which I came across your presentation. First of all, I like that you are interested in this field of maternal nutrition. That's good. But then when you come to the method section, if you see, the topic of your study was like study on awareness and utilization of government schemes on maternal nutrition in urban women in Telangana. Okay. But when you came down to the objective, it was only assessing the schemes at ICDS centers. Okay. Now, you mentioned in the topic that you're also going to study the utilization, but I didn't find any of the results that were related to utilization. Right?
80% of the beneficiaries are there.
And secondly, like, what was your study setting? Where did you do this study?
Sir? I can't.
What was your study setting?
It was a simple random selection sampling. Sir.
No. I mean to say, which place you collected this data? You said you collected the data.
Hyderabad Urban Area Center, that is Haras Center, sir. That is 3 Anganwadi centers I have listed, sir. And
so now what you see is that your 100% of your respondents were aware is one of your findings. Okay.
And your beneficiaries are only 80%, sir.
Yes. Yeah, but
10% are the private hospitals. They are going for the private hospitals.
Yeah. You see, when you do such kind of a study, you should be very much aware of the study setting that we are going to select. Okay, if you select a ICDS center and if you inquire about the beneficiaries already getting those services, so the awareness level will be definitely be higher. Secondly, like you took only 50 women. So what was the basis of choosing only 50? Like why did you?
3 working days I had been there for Anganwadi centers. So within 3 days I had to collect the data. So
So you
simple.
had kept a deadline of 3 days. Okay, so that's
Yes,
too
sir.
short for a study. And again,
Because of
if you come
seminar.
to the if you come to the conclusion, then do you feel right to study just 50? Hello, your conclusions are too much generalized and they're not based on your results. If you see, if I see the first slide of your presentation, yeah, first slide, if you go now, this is not in line with your objective, whatever you have presented in your first slide. So as with the previous participant, I said, no, whenever you are planning a study, the objective is very important, and the way you select your objective, the results which should come should be in line with the objectives, because you intended to measure something and you land up measuring something else and presenting something else. So that is not acceptable. And then the conclusions should always be based on your study findings. It shouldn't be generalized that you are saying that it should be implemented all across India. But you see, when you roll out a program, there are many operational issues with the program, the running of the program. So you didn't study them. So it might happen that there are certain issues for which it is like successful in Hyderabad, but it may not happen the same way in other parts of your state or in other. So you're too much generalizing your but you're not saying anything based on your research. You are saying something that is very general, that should be done. Okay. So you take care of these things when you plan to. This is a very small study that you have done. So once you do it on a larger scale, and you need to have more robust methodology for this, right? So thank you so much. Now, Joshi sir, can we invite the third participant?
Yes.
Hello?
Yeah.
Okay.
Go on.
Okay. So the next participant is Dr. Trishna. Dr. Trishna, are you ready? Are you there?
Yes, sir. Yes, sir.
Okay.
I'll just
So
share
you
my
can,
screen, sir.
Yes.
Sir, is my screen visible?
Yes, it's visible. Make it to full screen.
Yes, sir. I've done it. Yes, sir. So shall I start?
Yes. Start. Go ahead.
Good afternoon, everyone. It is an honor to present an oral paper in front of you. I'm Dr. Trishna Mohanty, third year resident at the Department of Community Medicine, Bharati Vidyapeeth Medical College, Pune. The title of my study is Study of Effect of Micronutrient Supplementation and Counseling on Malnutrition Among Children from Slum Areas. Undernutrition is a major public health problem in India. Protein, energy malnutrition, and micronutrient deficiency are frequent problems among the rural, poor, and urban slums in India. To know the exact change with micronutrient supplementation, the study was done. The objectives of my study were to measure the proportion of children regaining normal weight for height after intervention among malnourished children from 2 slum areas in Pune city, to calculate the time required to regain normal weight for height, to find association between time taken for regaining normal weight for height and few socioeconomic indicators like age, sex, religion, and immunization status, and to measure the proportion of the children relapsing or re-entering to severe acute malnutrition state or moderately acute malnutrition criteria. So the study design was experimental before and after study. All SAM and MAM children of the age group from 6 months to 6 years coming to a CMAM clinic, that is community-based management of acute malnutrition, were included. They were prescribed monthly micronutrient supplementation by the investigator with the dietary counseling to the guardian. Before getting the supplementation, their height and weight and immunization status was checked. They were followed up every month for 1 year. We have set operational definitions like relapse were those children who became SAM or MAM again within 6 months after achieving the normal stage, and re-entered was defined as becoming SAM and MAM again after keeping 6 months of normal stage. The supplementation included calcium, vitamin D, vitamin B12, zinc supplements, vitamin B complex syrup, iron and folic acid syrup. So the key results were out of 189 malnourished children, 38% children regained normal weight for height. This is there, the graph shows the age and gender-wise distribution of the children. And the average time taken was 3 months. Older children took less time to regain normal weight for height. And more than 1/3 children relapsed and only one child re-entered the malnourished state. Time taken was not associated with gender, religion, or immunization status. The p-value was not significant. The micronutrient supplementation contributes in improving the nutritional status of the children. Weight for height was significantly improved after intervention. So what did my research exactly contribute? Like as on today, there is no program targeting the micronutrient deficiency. So with this study, we underline the importance of micronutrient deficiency, and the supplementation brings tangible effect on the nutritional status of malnourished children. Along with balanced diet, proper sources of micronutrients are also important in the diet for the optimal growth of the child. So in the future, government may think in the direction of micronutrient deficiency and not only provision of protein and carbohydrate based diet. There shall be regular and free of cost micronutrient supplementation from government facilities for all malnourished children attending ICDS, VCDC and CTC centers. Thank you.
So thank you, Dr. Trishna. Now this is open for discussion.
Hello.
Hello, sir.
Any of the participants have any putting? Yes, sir. So there are no questions in the chat box. So I think you can ask if you have any questions.
Dr. Trishna, hello.
Hello, sir. Good afternoon.
I'm audible. Your step was right, but tell me one thing: how you selected them? It's like what sampling technique you used to utilize to select the children?
Sir, actually, we took all the children coming to the clinic. We have a collaboration with a CSR group named YARDI. We go to their CMAM clinic twice a month. Since 2 years we are doing this. So I thought of doing a study on those children. So I took all the children coming to those clinic, and only the SAM and MAM children were included in the study. Basically, only the SAM and MAM children were attending the clinic.
Hello?
Normal children were not attending the clinic.
Okay. So where was that clinic? It's like that clinic is nearby to your study area. That's
Yes, sir.
nearby.
In our adopted slums of UHTC, sir, in Bharatiya Vidyapit Medical College, Pune.
Okay. So and then so you means like for how many days? For what is the time period of your study? How many years?
Sir, I took the data from January 2019 to December 2019, and then I followed up them for 6 more months.
Okay.
Then I checked for relapse and re-entered into the SAM and MAM categories.
Okay, those all the children, Simon ma'am, you selected them, and then only counseling you have done, or something else you provided? Treatment also
Some micronutrient supplementation was given. There's a calcium syrup, multivitamin syrup, iron folic acid syrup, like those, all the micronutrient supplementation was given, sir.
For weight and all these things, food provision?
No, sir, not food.
So you counsel them? What you done?
Yes, sir, we counseled the mother, sir, regarding, and sir, we had help with the community modulators of that CSR group also. They did most of the dietary counseling. We were more focused on the health checkup and the micronutrient supplementation.
Okay. Okay, then nice presentation. And again, I'll Dr. Manish, if you want to ask.
I would like to I'd like to ask a few things, and also like see, Dr. Trishna, as I can see from your study topic, it's effect of micronutrient supplementation, number one.
Yes,
Second
sir.
is the effect of counseling on malnutrition. And the
Yes,
third
sir.
point that you mentioned, important in your topic, is among slum areas. So
Yes,
it
sir.
appears from your topic that the study setting that you are going to do
Yes,
the
sir.
study, you have done the
Yes,
study,
sir.
is actually in the slums.
Yes,
But
sir.
when I come to see the presentation, it becomes clear that you have not done in the slums, but you have done at some rehabilitation center.
No,
Right?
sir, it is in the urban slums only. In the slum, we have taken a Anganwadi center. In that, monthly twice, CMAM clinic was being held. In that, and in that clinic only, all the mothers used to come with their children. It is in the slum area, only the Janta Vasahat area and Ambedkar Wadi area in the Pune city, near Market Yard area.
Okay, so you
It
could
is in
have
the adopted urban slums of Bharati Vidyapith.
so in the topic you could have a bit made it more like in line
Okay,
with the
sir.
objective. And
Okay, sir.
secondly, uh, like what was your intervention exactly?
So micronutrient supplementation was given, and dietary counseling to the mother was given, and also with the we used to do general height, weight, and immunization status checkup also, and on every visit.
Okay, so the intervention that you are giving, is it the standard recommended intervention that is recommended for SAM children, MAM children, or you have devised your own intervention?
Sir, not exactly standard, because sir, according to the NRC, the SAM children they have to be technically in the center, admitted in the center. But we were not doing that, sir. We were only giving on a micronutrient supplementation.
Okay, so there is a question from a participant as well. Like, how were the SAM patient not admitted, and how did you send them home without appropriate treatment, only micronutrient?
Sir, we didn't. Sir, we actually give them the referral to our hospital, and we followed up. They were coming to the hospital, but we ourselves we didn't admit them. We first sent them to our hospital center.
But they were admitted somewhere, no?
Yes, sir.
They
Afterwards,
need
they
to
were
be
admitted,
admitted.
but we ourselves we didn't admit.
So once they get admitted, they are given a standard treatment that's recommended at that
Yes, sir. Yes, sir.
nutrition
That's the
rehabilitation
pediatric
center.
department was seeing that.
You gave, or they gave the micronutrient?
So they were sir doing
Who
that
gave this
proper
intervention?
treatment. Yes, sir. We just give the intervention. Treatment part was under their counsel. We just referred.
Dr. Manish, any other
So
presentation?
here you see that there's a problem here. Like, sir, there's one more, sir. After this, there is one more presentation after this. Okay. So okay. So first of all, like you need to define your intervention very well. So like it's a bit confusing. Like if you're using, if it's a standard one, if it's a new one, if you are saying, then your topic was micronutrient supplementation contributes in improving the nutritional status. So where is the control group? Then there's no control here. Then if you are using a standard one, like as you say that they were going to admit it to a hospital, so they might be getting a standard therapy. So in that case, I think it would have been more beneficial if you would have studied why it worked in some and why didn't it work on some other children. And the results, mostly you are concerned, the result, if I can see, it is mostly concentrated on the time of
Yes, sir.
if you, how much time they require to gain back the things. Counseling effect, again, you didn't have any findings on the effect of counseling. And in the conclusion part, if you see, just go back to the last slide of the conclusion. The first line you say, next slide. As on today, there is no program targeting micronutrient deficiency. Are you sure?
Sir, only vitamin A is being covered, sir. Rest of the micronutrients are not being covered.
But now in Anganwadi centers only, your iron is available from for children 6 months onwards. After 6 months of age,
Yes, sir. Iron folic acid syrups are available.
Okay, so it is under which program?
Sir, Iron Plus initiative, sir.
So you see, there are some
Anemia Mukt
programs.
Bharat also, Anemia Mukt Bharat covers it.
So you cannot say as of now, like this becomes too much of a generalization that there's no program.
Sir.
So you need to have an extensive search of literature. There are definitely programs
sir.
on micronutrient deficiency. And the results, again, what you say, no, they are not, recommendations are not in line with your results. So you have to take care whenever you present that whatever recommendation you give should be based on your study. It shouldn't come from elsewhere what you have read.
Okay.
Right, but nice presentation. And first of all, I like that you gave up the cross-section study and attempted a experimental study design. So, okay, thank you. And I just see if there are any questions. There are no more questions. So we can move ahead with the next presentation.
And Dr. Manish, this is Vishal Shastri here. Dr. Samina has some challenge with her audio. I'm connecting her through my phone, and I'll request my colleague Anupam to actually share her presentation.
Okay.
So I'll share her slide, Vishal.
Yeah. And I'm connecting Dr. Samina. I mean, who's already connected actually. Dr. Samina, you can start, I believe.
All right, thank you.
Is she audible?
No, I cannot hear.
Whom I have had the privilege of listening to and learning from over the past 2 days. Respected members of the faculty, revered participants, a very good afternoon to all of you. Today I will be presenting a paper on the nutritional profile of children in orphanages of Kashmir Valley, a cross-sectional study. And this research article was authored by myself, Dr. Samina Yusufdar, Professor Rafi Rashid Kaul, late Professor Muhammad Rafiq Mead, and Dr. Tawhida Ara. So could we move please to the next slide? May I have the next slide, please? Yes. So moving on to the introduction, who is an orphan? The most widely accepted definition for an orphan is a child who is under the age of 18 years and has lost either one or both parents as a result of bereavement or abandonment, which could be due to a variety of causes: incarceration, alcoholism, drug abuse, or poverty. Now, according to the report of the UNICEF and way back in 2015, and this has not been revised as of yet. I checked yesterday, actually. The number of orphans worldwide stands at 153 million, which is a staggering number. And the number of orphans in India is approximately 55 million children in the age of 0 to 12 years. We have to remember that India contributes to 35% of the overall global burden. And according to a report by Save the Children, UK, there are 2.14 lakh orphans in Kashmir, and 37% of them have been orphaned because of the armed conflict that has been prevalent here over the past 2 decades. UNICEF estimates that at least 2.2 million children worldwide live in orphanages, and the reason for this is not primarily cited.
Dr. Samina, hello.
Yes, sir.
Hello.
Yes, sir.
Dr. Samina, directly go to the objective. This such a long introduction is not much required here. Directly go to your objectives of your study.
Could you please go to the objective side? The next one. Yeah. So, keeping this background in consideration, we went on to carry out this study with the following objectives in mind: to assess the nutritional profile of children living in orphanages of Kashmir Valley, to assess the prevalence of underweight for age and stunting among children living in orphanages of Kashmir Valley, and to assess the factors associated with thinness and stunting in the defined population. We actually did overweight as well, but since the number of slides had to be limited to 10, I could not say those results. The methodology that I followed, the study was conducted in selected orphanages in Kashmir Valley over a period of 1 year, and it was conducted among children belonging to the 10 to 18-year age bracket. A cross-sectional study design was adopted and multi-stage random sampling was run. We took a sample size based on a prevalence of 50% so that we could get the maximum sample size, since we did not have any previous data. The next slide, please. So the children in the age group of 10 to 18 years with a minimum stay duration of 3 months in the institution, they were included in the study because that would be the minimum time that would take for effect to manifest in the children. And the exclusion criteria basically it consisted of communication gaps, such as children suffering from mental retardation, children afflicted by deaf mutism, and children not providing consent. Kashmir Valley is geographically demarcated into 3 zones, the north, south, and central zones, and from each zone we selected 2 districts by random sampling, and from each district thus selected 1 registered and 1 unregistered orphanage, male and female each, was selected by random sampling. So we took one from, there's an unregistered and registered, like I have shown, and of course this was subject to the availability of such orphanages and the willingness to participate in the study. And from each orphanage, proportionate allocation of children was then done till the requisite sample size was reached. A pre-tested, pre-structured study instrument was used to assess their dietary intake and other factors that might have a bearing on the nutritional profile of the study participants. And then the children underwent anthropological assessment as well in terms of weight, height, and BMI. So ethical clearance was sought and obtained from Institutional Ethics Committee at Sora. Informed consent was taken from the Director of Social Welfare Department as well as the heads of the institution. The nature of the study and the procedure involved was explained to each child individually, and their consent was obtained as well. The subjects were interviewed and examined on a one-to-one basis, and confidentiality was maintained at all times. And the data generated was analyzed using SPSS. So moving on to the results now. Can we have the next slide, please? The first figure depicts the distribution of the study subjects as per their demographic profile. As we can see, I'm sorry, I'm not able to see clearly, but since I remember the results, I guess I'm going to have to take a guess away. So 60% of them, a majority of them belong to 10 to 14-year age group, and most of them were male. Most of them were paternal orphans, and most of them belonged to the lower socioeconomic class 4 and 5 as per the PGSSR socioeconomic classification. That was used because it could be used in rural as well as urban areas. May I have the next slide, please? This is a figure depicting the prevalence of illness and the associated factors among the study participants. The overall prevalence of illness was found to be 7%. Now we have these arrows at the bottom of the slide, and these factors which would have to have a significant association with the prevalence of illness in the study population. So 10 to 14-year age bracket was found to be more prone to thinness. Those who were living in rural orphanages, they were found to be more prone, and children with a stay duration of less than or equal to 1 year had a higher prevalence of thinness as compared to those with a longer stay duration. Also, those taking a diet that was deficient in calories and protein had a higher prevalence of thinness, and thinness was also statistically significantly associated with poor personal hygiene. have the next slide, please? This is the figure depicting the prevalence of stunting and the associated factors in the study population. The overall prevalence of stunting was found to be 37.3%. And again, I have highlighted those factors which were found to be statistically significantly associated, which had higher rates. So stunting as opposed to thinness, it was found to be more in the 14 to 18-year age bracket. Now, this could be explained probably because this is the age where children are growing and they have to go through that puberty and growth spurt. It was found to be more among males. This was more in urban areas, and it was this is also the arrow has been missed over here, but it was found that with the increase in duration of stay in orphanages, that is, once the duration of stay increased to more than a year, the prevalence of stunting actually increased significantly. And it was also associated with a history of physical assault in these orphanages. I have also done binary logistic regression. Again, like I said, I could not share those results, but most of those results were in concurrence with the results that I have already depicted, except that physical assault on binary logistic regression did not show to have a significant, significant association. So in conclusion, I would like to summarize that the prevalence of thinness and stunting observed among the children living in orphanages in Kashmir Valley was found to be 37% and 37.3% respectively as per our study. And this is an urgent call for action to implement remedial measures so as to enable this vulnerable and marginalized section of society to live a potentially healthy and productive life. And various measures that we can take in this direction. So would you like me to go on, or would you like to save that for questions?
Yeah. Hello.
Yes, sir.
Hello. Huh.
Yes,
Hello,
sir.
Dr. Sabina. Hello.
Yes, sir.
And it's a nice presentation. And Miss, like, I just want to know that this is how many orphanages are there? Miss, like, how you selected a particular orphanages? How many orphanages are there?
So the list of orphanages, it depends. We have registered as well as unregistered orphanages, so we cannot have a conclusive number. And at the time that I got the list from the social welfare, which was in 2015, they had only 14.
Okay. Now, I just want to know that you mentioned that multi-stage sampling was used. So,
The call has
so multi-stage sampling, how you utilize that multi-stage sampling? Like,
kindly give me a minute.
You're connected. You're connected, Dr. Samina.
hello.
Yes, sir. Sorry, I'm not. It's still connecting on my laptop.
No, I just want to know
You can
how multi-stage sampling, you said a multi-stage sampling technique you utilize. So how you utilize that thing?
So about the sampling, how we went about doing the sampling. Sure, sir.
Yeah.
So
Yeah,
initially, we selected 2 districts from each of the zones that we have in the valley. So that gave us a total of 6 districts from which we had to select the orphanages.
It's like how this district was selected, why this district was selected, only this district was selected.
Sorry, sir, I'm not able to get that question. I'm not able to hear the question, sorry.
I want to know that why only these, how these 2 districts were selected out of total district, why only those district was selected. And second thing, okay, then leave it that. So why you have taken only 10 to 18-year children?
Sorry, sir. Yes, sir. So actually, you're back on line and I'm able to hear you now. Could you please repeat your question, sir?
Okay, I just want to know one more thing, that why you selected only 10 to 18-year children?
Yes, sir. So there was a reason for that. Actually, while we were doing the study, we were also doing a psychiatric evaluation. We were trying to find the prevalence of psychiatric morbidity among the children living in the orphanages as well. So the scale that we were using, which is the modified mini score, found that it was not comprehensible to children below the age of 10.
No, actually, ma'am, why I ask you this thing, malnutrition or nutrition profile or undernutrition is very much common in age less than 10 years also, no? But you selected this. So
that's the reason that I'm giving that.
yeah, because that means that this study is a part of some other study. Means like
Yes, sir. It was done in conjunction with another study as well.
Sure. Okay
So
then.
did you?
And the 18-year age limit that we have is because that is the maximum age up to which the children are actually allowed to live in the orphanages, after which they are forced to move out.
Okay. Okay then. Thank you. Dr. Manish, your turn.
Yeah. Actually, I was also interested to ask that particular question. Why 10 to 18 years? Because by the time you reach, it's too late to do some implementation, right? Something you take corrective measures. So, okay, then since you say that's part of a different study, you have said that you took consent. Can you, do you know what is the difference between a consent and an assent? And which one is applicable here? Hello, can you hear me?
Below the age of 18 years. So, as such, we would have been required to just take the permission from the heads of the institutions who were the caregivers in their case, and that written verbal written consent we have obtained from the heads of the institution. But we wanted to go that step further as well and take the consent of the individual children as well, because some of them might not have been comfortable with the.
So what do you take? Like, is it consent we take, or we take a assent from for participation in case of an adult who is less than 18 years of age? And one more question is like, what was your non-response in your study? Like, was there any child who refused to participate?
No.
And
we had factored for that already. We had I had taken 20% non-response rate already, but there were no non-responders actually, because for them it's more like direction from the heads of the institutions that this is something that you have to do, and then they go and.
But then how does it qualify ethically? Because you are seeking an ethical permission here as well. And is it ethically correct that on the directions of the whoever is the owner of that orphanage, you are going ahead with the study on each and every orphan without his consent or assent to participate?
No, we have taken consent from the students individually as well, from the children individually as well, like I mentioned. But we.
Okay, one last question I want to ask. Hello.
The children. So the consent that we obtained from the caregivers, the primary caregivers, that is the heads of the institution, that does, and this has of course was discussed in the ethical review.
Yeah, but actually, because of the 100% response that you have got, no, that came to my mind that whether any student had the freedom to opt out of your study as well. And one more thing I would like to say is that your study, if you mentioned in the objectives, no, your objectives are you want to study the nutritional profile. So when we study a nutrition profile, other than anthropometric measurements, there are few more things which we do. But as I can see from your results, they are mostly concentrated on the anthropometric measurements, like stunting you have measured. But what about the other things? Did you find anything on clinical examination, any malnutrition deficiency? Did you do a biochemical testing for anything? Or So accordingly, you can modify your topic as well, or the objectives. You can put in that way, because the results are mainly concentrated to one or two of the basically two of the objectives. The remaining two objectives are not that adequately addressed, right? Hello. So that's it. I think this was a good. You have a good presentation, but these were some issues that I could get through this presentation. Let me check if there are some questions in the chat box. There are no questions here. No. So there are no questions. So, Joshi sir, can we conclude here? Hello.
Yeah, yes. Conclude.
Okay, so thank you so much, organizers, for this opportunity to chair this paper presentation sessions. It was really exciting, and in a very short time, you did all this, and still you got some papers. But then, as we were discussing in the previous sessions, there's a more of a need for going for implementation research and going ahead of the cross-sectional studies, which we are doing mostly in this field. So hopefully when we do it in the next time, we get some good papers on focusing on implementation research as well. So thank you so much, Amir sir. It's over to you now.
Thank you. Thanks to the chair.
Thank you, Dr. Amir Bhai.
Yes, sir.
Amir sir, you can take forward from here. Like, I think we are done. There are no more participants.
Thank you. Thank you, Dr. Joshi and Dr. Manish for chairing this session. And it was interesting to see that the work on research on malnutrition at various forums are going from program policy to also orphanages that are that might get missed out by. So it's very important, and as you rightly pointed out later on, these, as has been discussed in this 2 days conference, we will be it will be required that we move ahead to operational research and implementation research. So I would like to thank both of you, and also I would like to thank the chairpersons of the poster presentation session, Dr. Somdatta and Dr. Farzana. Dr. Farzana is from the Hamdard Institute, Professor Head Community Medicine, and Dr. Somdatta is Associate Professor Community Medicine in UCMS. So now we are here for the vote of thanks. I would like to invite Dr. Mona Lisa. She is a faculty in All India Institute of Health, Hygiene, Public Health in this Kolkata. So I would now like to invite Dr. Mona Lisa for the vote of thanks.
A very good afternoon. Thank you, sir. Thank you, Dr. Amir. A very good afternoon to our honorable chairpersons, invited guests, faculty members, students, and dear participants. I am really, it has been challenging 2 days of Poshancon 2020. And over the past 2 days, we have heard a galaxy of experts and MIYCN leaders sharing their deep insights into several important issues of MIYCN. Today morning, our technical session started with a very lively session on quality assessment in Poshancon Abhiyan. My heartfelt thanks to our speakers, Dr. Pragya, Additional Professors, Community and Family Medicine, AIMS Patna, and Dr. Tanu Midha, Professor and Head Community Medicine, GMC Kannauj, for presenting their observation on the quality aspect of Poshancon Abhiyan directly from the field. I am also immensely thankful to our chairpersons, Dr. C.S. Panda sir, Member National Council Poshan Abhiyan, Dr. C.M. Singh sir, Professor of CFM AIMS Patna, Dr. Martolia, Principal GMC Saharanpur, who shared their views on the quality. Professor and
HOD, Community Medicine, GIMS, Greater Noida, and Chairpersons Dr. Shurekha Kishore, Executive Director and NMC Member, AIMS Gorakhpur, Dr. Dinesh Badyal, Program Director and FIMER Regional Institute, CMC, Ludhiana, for sharing their valuable views on importance of MIYCN integrated curriculum. We are immensely thankful to our Joint Secretary and Speaker, Dr. Ravneet Kaur, Associate Professor, CCM AIMS, New Delhi, and the Chairperson, Dr. Vikas Bhatia, Executive, for an insightful discussion on maternal nutrition, a very critical but often missed. Now, from the bottom of my heart, I sincerely thank Dr. Lalit Sankhe, Professor of Community Medicine, Grants Medical College, Mumbai, for presenting survey report of our work on MIYCN and private health sector. Special thanks to our chairpersons, Dr. Vidya Thobi, Chair, Food and Drug Committee, FOGSI, and Dr. Aram Shentil, President, IAP, Tamil Nadu State Chapter, for providing their valuable suggestions. I must admit that we have been really fortunate to have renowned and diverse identities from the public health academia, as well as various organizations of the likes of Dr. Ratan Srivastav, Professor of Community Medicine, Prasad Institute of Medical Sciences, Lucknow, Dr. Sonu Goyal, Professor of Community Medicine, PGIMER, Chandigarh, Dr. Sumit Malhotra, Additional Professor, CCM, AIMS, Delhi, Dr. Shailesh Jagtap, Senior Technical and Program Advisor, Alive and Thrive India, and Dr. Alok Ranjan, Lead for Nutrition, BMGF, as our esteemed panelists. I sincerely thank Dr. Sebanti Ghosh for the discussion on Poshan Abhiyan and putting emphasis on implementation research. I also take this opportunity to extend a very hearty vote of thanks to all the presenters of scientific papers and posters for gracing your important work and sharing with us your findings and opinions today. I also sincerely thank our chairpersons for the sessions, Dr. H.S. Joshi, Professor and Head Community Medicine and Family Medicine Department, AIMS Gorakhpur, and Dr. Manish Singh, Assistant Professor, Community Medicine Department, RMLIMS, Lucknow, for enlightening us with their enthusiastic remarks. I would also like to immensely thank our esteemed chairpersons of our poster sessions, Dr. Farzana, Professor and Head Community Medicine, Hamdard Institute of Medical Sciences and Research Center, Delhi, and Dr. Som Datta Patra, Associate Professor Community Medicine, UCMS and GTB Hospital, New Delhi. Finally, I would like to mention that an event like this cannot happen overnight. It requires planning and a bird's eye for details. The wheels start rolling weeks ago. And so let me thank once again to all those who have been involved wholeheartedly in this process, that is the organizing committee, the scientific committee, and the technical committee, for bringing together this virtual conference to such a grand success. This is just the beginning, and we hope many more will follow. There is a famous quote that a pessimist complains about the wind, an optimist tries to change it, and a leader adjusts the sail. We have truly found our leaders in our organizing committee chairperson, Dr. Sanjay Jodhpe sir, co-chair Dr. A.M. Kadri sir, chair Dr. Pragati Chabra ma'am, secretary Dr. Khan Amir Maruf sir, and joint secretary Dr. Ravneet Kaur ma'am. I cannot thank everyone enough from Alive and Thrive team, especially Dr. Sebanti Ghosh, Dr. Shailesh Jagtap, and rest of the team for their appreciating involvement and their willingness to take on the completion of tasks beyond par. Together, this is our journey from aspiration to achievement. Together, this is our journey towards shaping our nation's value for a sustainable future. With these final words, I shower my heartfelt gratitude to everyone who directly or indirectly rendered their support in the success of Poshancon 2020. Thank you, everyone. Till we meet again.
Thank you, Mona Lisa. Dr. Mona Lisa, thank you very much.